our distinguished dignitaries presented with us today. I would welcome Dr. Venkat Goyal Sir, Director and President of Riddhivinayak College of Nursing and Riddhivinayak Multispeciality Hospital, Dr. Madhvi Goyal, Vice President, Riddhivinayak Multispeciality Hospital and Riddhivinayak College of Nursing. I will welcome our observer for today, CPD, Dr. Vidya Gupta ma'am. I extend a warm welcome to Professor Dr. Anupama Oak ma'am, Principal of RVCon, and Mrs. Dipti Dotia ma'am and Professor Usha Menon ma'am.
As we gather here today, let us begin this auspicious occasion with the traditional lamp lighting of the ceremonial lamp. Lighting the lamp symbolizes the victory of knowledge over ignorance and the journey from darkness to enlightenment. I now humbly request our honorable dignitaries to kindly come forward and inaugurate this CPD program by lighting the ceremonial lamp.
उनको वो सॉन्ग यहाँ से चला गाने के
Now I humbly request Dr. Vidya Gupta ma'am and Professor Anupama Oak ma'am, Professor Usha Menon ma'am, and Cicely sister and Sangeeta ma'am
to come and light the ceremonial lamp.
to come and light the ceremonial lamp. We welcome Cicely sister for the lighting of the lamp.
ये क्या है? Sorry. Thank you, honorable dignitaries, for lighting the lamp and spreading the aura of positivity. Now let's begin this event by surrendering to God and through devotional song of Lord Ganesha.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणैशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानपरात्मने गानोत्सुकाय गानमत्याय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थानिने गुरुविक्रमाय गुरुरगत्याय गुरुगुरुवे गुरुदन्त्यकलच्छित्रे गुरुधर्म सदा रक्षाय गुरुपुत्र परिपात्रे गुरुपाकन्दकन्दकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गोदगोपाय गन्धमत्याय गोजयपदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि.
With this divine ambience and the feeling of heavenly blessings, let's begin with our session. Stroke and recognition and acute management. When it comes to stroke, every minute matters. Early recognition can change the course of life. When it comes to every minute, our first session focuses on one of the most critical aspects of stroke care, stroke recognition and acute management. To guide us through this important topic, we have Professor Dr. Anupama Oak, Principal of Riddhivinayak College of Nursing. It's my privilege to introduce Professor Dr. Anupama Oak, ma'am. Madam completed her Masters in Obstetric and Gynecological Nursing from SNDT University and also a PhD holder. She has 24 years of teaching experience and 12 years of experience at KEM Hospital in various departments, making a remarkable 36 years of professional experience in the field of nursing and healthcare. Madam's academic achievements are truly remarkable. She has total 114 research publications, which includes 100 international publications and 14 national publications. In addition, Madam has actively participated in 1991 International and National Conference as a keynote speaker, organizer and presenter, reflecting her strong dedication to academic excellence and professional development. Ma'am has been serving as the principal of Riddhivinayak College of Nursing for the past of 5 years. And prior to that, she worked at KDA Nursing College for nearly 15 years. She has also served as a BOS member at MUHS, coordinator of Foreign Exchange Program, and is currently a PhD examiner and PhD guide at MUHS, Rajiv Gandhi University of Health Science and JJT University of Rajasthan. Madam has been a member of various committee of MUHS and also associated with Maharashtra Nursing Council for various academic and professional activities. With this, such a tremendous experience and expertise, we are truly honored to have her with us today. Now I invite Professor Dr. Anupama Oak to take over the session.
Now we felicitate our dear Observer ma'am, Miss Vidya Gupta ma'am. Please come at the stage ma'am. मैम ने बोला है कर्सर क्यों चाहिए? अरे होना तो चाहिए कर्सर.
So, no, to इधर ही रोक because I want to move. You will change the
Yes,
slide, huh? Okay, before starting my session, I just want to show one skit, small skit, that is a emergency management, how we are going to see in the stroke patient. Thank you. Mic देना. You sit.
Good morning everyone. So we are the students of 4th semester from Riddhivinayak College of Nursing. Today we are going to a small skit on emergency stroke management. So the first scene is starts in the casualty where the client approach the casualty. So after the client coming, firstly I will activate the EMS, which is emergency medical system. After that I will assess the patient to see the sign of strokes. So first the main 4 steps are elaborate as fast. First is F, which is the golden sign. F means the facial drooping. So in this I will be seeing the client's facial expressions. In that I will see the face. So as we can see, the client has drooping to his lip to the left side. Then the second is A, which is arm weakness. I will ask the client to raise her arm. Ma'am, can you please raise your arms? Thank you. As we can see, the client has difficulty in raising the left arm. She is raising the left arm in a shivering manner. So third is S, which is speech difficulty. I will ask the patient to a simple question to answer it. Ma'am, can you please tell your name?
Yasmin.
So as we can see, the patient is difficulty in saying her name appropriately, and the last is time. In this we will include the call or emergency department for the fast and quick early treatment and assessment of the patient for imaging of the stroke.
So we'll see that our procedure is like emergency medical system we have to activate and send the patient to the casualty as at the earlier, so that they can take action, and they will send the patient after quick assessment. They will send for the taking X-ray, taking CT scan, doing CT scan or MRI as per the doctor's order, and we can save the time of the patient, and we can really save his life to going for any disability or deformity in of the stroke. Thank you. Thank you. So with this kit, we must, we have, just give me some mic. So in stroke management, first 60 minutes are very important. In that 60 minutes, we have to assess the patient, send for the CT scan, MRI after assessment in the casualty, and then the patient will be transferred to further management. So that has to happen within 60 minutes, your assessment and treatment has to be done, then only we can save the life of a patient. So we'll start with my introductory slide of this. Stroke is a leading cause of disability and death worldwide, with the approximately 15 millions people affected annually. Early recognition and management are crucial for improving patients' outcome. This presentation will equip staff nurses with essential knowledge and skills to identify stroke symptoms quickly and implement effective acute management strategies. Here we are the first line healthcare workers or healthcare workers, you can say, or assistant, where we can assess such signs and symptoms and immediately we can refer to the doctor or concerned department. We will also assess your understanding through pre and post test, ensuring that you are well prepared to provide optimal care for the stroke patient. You must have given the pre-test. I hope you have done your pre-test everything. Next slide. Now if you see this definition, there are so many definitions which I want to show in front of you. A stroke is a medical emergency where blood flow to part of the brain is cut off, completely cut off. That happens when a blood vessel blocks or bursts. Without blood or oxygen, brain cells get hurt and die. Second definition for this, it is also called as a cerebrovascular accident, that is CVA. You must have learned your nursing training program. It is a medical emergency that happens when blood flow to part of the brain is blocked due to the blood clot, or when a blood vessels in the brain burst. When any artery gets burst, there will be severe hemorrhage in the brain, and then brain tissue will not get enough oxygen and nutrients, causing brain cell to die within a minute. So your 1 minute is 60 minutes are very important to move the patient fast to further management. A stroke is a medical emergency that happens when something prevents your brain from getting enough blood flow. A block of blood vessels or bleeding in your brain can cause stroke. So this is understanding about the stroke. I hope you understood this. So we can proceed further. Next one. So incidence, if you see, globally approximately 12 million new strokes occur each year, with 1 in 4 adults experiencing a stroke in their lifetime. In India, the crude annual incidence ranges from 105 to 172 per 1 lakh people, making stroke a leading cause of death and long-term disability. Global and local numbers, if you see, global new cases, 11.9 million new strokes annually it is noted. Lifetime risk, 25% of adults over age of 25 will have a stroke. India incidence 105 to 172 per 1 lakh population per year. Age impact, if you see, over 50% of global strokes occur in people under 70, and about 15% to 25% of cases in India affect younger adults under 45. So you can see who are at risk of stroke. Next one, we will understand the different types of strokes. There are the ischemic stroke prevalence, hemorrhagic strokes, and importance of symptoms recognition. So there are mainly 2, if you can see, one is hemorrhagic and one is ischemic. Now ischemic, because of the blood clot in one of the, there will be formation of blood clot in one of the artery. Ischemic strokes accounts for approximately 87 of all strokes, primarily preliminary caused by blood clots obstructing blood flow to the brain. So you can say, if there is no blood supply to the brain, all the neurons and blood cells, those are 19 millions. So that cells will get affected, and there are the survival chances are very less. Hemorrhagic strokes. Hemorrhagic means if there is any blood vessel gets rupture or burst. Hemorrhagic strokes occur when a blood vessel in the brain ruptures, leading to bleeding and increased intracranial pressure, requiring immediate medical attention. Now, importance of symptoms recognition. How we'll do that? Timely recognition of stroke symptoms using FAST or BFAST is very crucial. on the skit it is easy. Well, when we are doing on the stage, when we are just teaching, it is easy. But when patient comes with such symptoms, we take very lightly. What is this? He only can speak, or he is just having numbness at the leg or on the hand. So that is just nothing. But it is very crucial thing. We have to assess and immediately refer to the concerned person. So it is significantly impacts treatment outcome and recovery potential for patients. Next one. Now main causes, now we'll see the causes and risk factors of stroke. So when you are talking about the stroke, main cause of stroke is ischemic stroke. So a blood clot blocks a blood vessel supplying blood to the brain, fats and plugs build up atherosclerosis or clots traveling from the heart, like like you can see in atrial fibrillation. Cause most blockages. Hemorrhagic stroke is a weakened blood vessel in the brain, leak or breaks upon. Uncontrolled high blood pressure or weak spots like aneurysm cause this type of bleeding. So hemorrhagic and ischemic strokes are very, very common. Now control risk factors. If you see the control risk factors, under this we can see lifestyle and medical. So related with the medical, we'll see first high blood pressure. Everybody must be knowing, if your blood pressure goes high, something will go wrong. So the single biggest cause of stroke, it strains and damages blood vessels. Now diabetes damages blood vessels and spread up to plug buildup. Heart diseases, conditions like irregular heartbeats, arterial fibrillation, leads travel from the part to the brain. High cholesterol leads to fatty deposit, closing of arteries. Smoking and tobacco chewing, it's very much harmful for the blood vessels. Wall becomes thickened, and that will be dangerous. Now if you concern with that is about the medical. In medical, high blood pressure and diabetes is the main risk factors for having this type of stroke. So we have to be very careful. And lifestyle related means you have to have a proper diet system and medical treatment you have to follow. You have to do regular follow-up and blood testing. So diet and weight, eating high fat, high salt foods and lacking physical activity, this risk will be high. Alcohol and drugs, heavy drinking and using illegal drugs like cocaine increase, or like there are so many non-medical drugs. Non-medical drugs means you can understand those are consumed on the street or anywhere, which are there is no doctor's prescriptions are required, easily available on the pan patti. Now many authorities are stopping this pan patti also because they are selling all these drugs. Are sedative and harmful to the person. So these are the main risk factors. And then unchangeable risk factors which we cannot change at all. It's like age. Risk grows higher as you get older. So you please take care of it, of your personal way, your family or your community, society at large. So risk grows higher as you get older, doubling every decade after age of 55. So chances of 45 to 55 is very higher in this case. Family history, having parents or sibling who had a stroke rises your personal chances. So these are, we have seen the rough causes and risk factors. So if you see the stroke symptoms, just now we have seen in the skit, facial, arm, maybe arm or maybe leg. Then vision loss, dizziness, confusion, then incontinence and tingling or numbness. So if anybody is having, don't ignore it. Immediately action has to be taken appropriately, adequately. Now we are coming to fast and be fast recognition. How will recognize such things? So in fast, it stand for face drooping. Face drooping you can see in one first image. Arm weakness, speech difficulties and time to call emergency services. Recognizing these signs is a crucial for timely intervention. So our timely intervention is very important. Our time has to be maintained well, and within golden minutes, I can say 1 minute, that is 60 minutes, is a golden hour for us. It's a golden hour for us to take the patient to give the patient to the safe hands. Now be fast. So be fast is another acronym components. It includes balance issue. B for balance, loss of balance of coordination. If you ask the patient to stand, so that their balance will go away and they will not stand properly. They may not have hand and legs coordination properly. If you see the eye changes of vision, they may see the blurred vision because of maybe high BP or sugar level high. So the vision will change. Then, no, it's okay. Last slide. Previous slide. Okay. Then face drooping features on one side of the face. Whichever side is affected, whether left side is affected, left side patient face will be get droop, or if it is right side patient may droop. Then arms and legs weakens in the limb. Limb may get weakness. S is speech, difficulty speaking or understanding others. They will not understand for that moment. Okay. Then time. Time is like emergency calling system is 911. Some places it is 112. It depends upon your hospital setup and hospital protocol. So time means you have to call emergency management system EMS 911 or emergency services right away. So this be fast and fast, these are the two main thumb rule of managing stroke patient. If you do this much also, you can save somebody's life, and going into the disability or any health loss, you will be the successful person. Next one. Now, importance of quick recognition. What is the importance of this? Quick recognition of stroke symptoms can save life and improve patient's outcome. Study shows that timely treatment can reduce disability up to 30%. They say that if you do immediate medical management of the stroke patient, 70% you can save life of the patient, and 30% they may get some disability. But that also you can prevent by doing some thrombolytic and thrombectomic treatment. We'll see later. Now, quick recognition of stroke is vital because time is brain. Every minute brain cells are starved of oxygen. They require oxygen and nutrients. Millions of neurons die. Early identification and fast medical treatment can drastically reduce permanent physical and mental disability. You have seen many patients, they are paralyzed. They says that in layman language, they says that lakwa. Many patients you will see at home, they are having paralysis or they are not able to function normal daily activities. So you can see such patient and you can save their life with your early smartness. We can preserve speech and mobility and ultimately save a life of a patient. Next one. Now, thrombolysis protocol for ischemic stroke. Suppose ischemic stroke is there. Ischemic means, remember, there may be some blood clot obstructing the arteries. And what happens in that? We have to save the patient's life. Now, what is thrombolysis? In that, we are giving thrombolytic drugs by injecting and reducing the clot, and we can save the life. The time window for administration of thrombolysis must be administered within 3 to 4.5 hours of symptoms onset to maximize patient outcome and minimize disability. So to minimize the disability, we have to start with the thrombolysis. So thrombolytic treatment, how it is possible? When you easily identify and send him your first aid for the stroke patient, you can do this and send the patient for the further management quickly. So thrombolysis with alteplase to 3 to 4.5 hours after acute ischemic stroke. So if you see, alteplase TPA is used to break down the blood clots in ischemic strokes. TPA was previously only approved until 3 hours post-stroke, and now it is increased. Full analysis of data from RCT is shown a favorable outcome is if treatment was given between 3 to 4.5 hours. So now if you see thrombolysis protocol for ischemic, in that again contraindications to the thrombolysis. Every patient we cannot do thrombolysis. There are certain contraindications where we cannot do. So American College of Chest Physicians, they are saying if If the patient is female, diabetic retinopathy or black rays or recent surgery if it is done, or weight is less than 60, or ischemic strokes more than 3 mo month ago, systolic blood pressure if it is more than 180 1 mm of Ag, or recent non-intracranial bleeding, traumatic CPR, recent invasive procedure, pregnancy, or patient is having on anticoagulant therapy. Such patient, or if the patient age is more than 75%, we cannot do this thrombolysis. We cannot follow this thrombolysis protocol. This is given by American College of Chest Physician. But if you see, American Heart Association is saying in different way. What there is, it is a similar only somehow. Major surgeries within 3 weeks. If the patient underwent for the major surgery, we cannot do this thrombolysis therapy. Ischemic stroke, if it is there more than 3 months ago. Systolic BP, same, it is like them American Association. If it is more than 180 mm of Hg or less than 180, sorry, more than 1 diastolic if it is more than 110 mm of Hg. If the patient is having dementia, recent internal bleeding within 2 to 4 weeks, with then traumatic or prolonged CPR if it is happened more than 10 minutes, then non-compressible vascular punctures if that lady is pregnant, or patient is on anticoagulant therapy, or if the age is 75. So last 3 factors are very common for all. So make sure that thrombolysis treatment, you cannot give each and every one. You have to take proper history of a patient, then we can implement it. Now European Society of Cardiology, what they are mentioning, relative contractility. I'm not talking about the absolute, only relative. In relative again they are saying advanced liver diseases. If they are having any advanced liver diseases, or systolic blood pressure is more than 180, infective endocarditis, acute peptic ulcer if they are having, traumatic resuscitation, non-compressible puncture site, pregnancy, anticoagulant therapy, and transient ischemic attack in preceding 6 months back. So what is transient ischemic attack? It is a mini stroke. They call it as a mini stroke. It is remain for a while and it will go after few minutes or few seconds. So transient ischemic attack, if it is there, don't ignore it. You have to do proper analysis and assessment, so that you can prevent further stroke. So TIA, transient ischemic attack, it is a mini stroke. Don't ignore it. This is the main point to inform you, to tell you. Next one. Now thrombectomy pathway. If you see now first management is what? You have to give thrombolysis treatment, and basically you have to see that main thing, patient will not more than 75 years old, and patient will not on, sorry, on anticoagulant therapy. So that, that heparin must be, patient must be getting, sorry. So patient will not be, see that patient is on which therapy, like heparin therapy, anticoagulant therapy, so we have to be careful. Now next management is what? Thrombectomy. Thrombectomy means removal of the stroke. If it is there, they will put the stent and they will remove, or they will do some small surgery. Like angiography, how we do for the cardiac condition, angiography. So similar way here we can do thrombectomy. It is indicated for patient with large vessel occlusion. Occlusion means when it is getting obstructed. Significantly improving outcomes when performed promptly in acute ischemic stroke. In acute ischemic stroke, if we are doing thrombectomy immediately with your quick assessment, we can save really life of the patient. Thrombectomy, it is an effective medical procedure for an acute ischemic stroke. A thrombectomy is a procedure that removes blood clots in the brain, in the brain's large artery with the catheter. They can do, they will insert the catheter, sometimes they will put the stent and then they will try to remove that clot. It increases the chance of recovery and lower the risk of disability in case of an ischemic attack. So the brief procedure, you can see the catheter is inserted through the artery, simple procedure. We think it is simple, but when the doctors are doing, it is a crucial task for them. right? Blood clots are removed or destroyed. They will remove or they will destroy. There are the various method has come. They will puncture, they will break, and they will do it. The blood flow returns to, and then the blood flow returns to normal, and we can save the life of a patient by doing thrombectomy, by removal of this clot. Then observe the golden period. Thrombectomy is effective within 6 to 24 hours. 6 hours are crucial, but maximum up to 1 day. I mean, 24 hours, we can save the life of the patient and we can prevent prevent him to go into the bad shape. So recognize the symptoms with be fast. So first we have to say be fast. We have already done. B means balance, trouble with body balance and coordination. See whether the patient has a balance of the body. So that is the main thing. Then face, one side of the face is paralyzed or drooping, you can see, and speech, slurred speech, or even unable to speak at all. Eyes, vision is one or both the eyes are getting disturbed. Then arms, a weak arm or numbness in the arm or tingling in the arm or fingers, it is the major, you can see the sign and symptom. And time, contact emergency medical system, that is 911 or 112, and based on your hospital protocol numbers. Next slide. Thrombectomy pathway. Now in this, how we are going, to whom we can go for again. Indications of thrombectomy. Consider thrombectomy for patient with large vessel occlusion. Thrombectomy will do only when the large vessel is getting occluded, not the small vessel. Small vessel we can do with the thrombolytic drugs. The drugs karke unka clot dissolve karke we can go ahead. But in the thrombectomy, if it is done only with the large vessel, because we are actually putting the catheter and doing the procedure. So if it is big vessel, only we can do this. So consider thrombectomy for patient with large vessel occlusion, as it significantly improves the outcome when performed promptly within the treatment window. Treatment window, I told you, 24 hours is the maximum treatment window. Then time of procedure. Thrombectomy must be performed within 6 to 24 hours of symptoms onset. Depending on imaging finding means when you are doing CT scan or MRI. That is the main tool for to know whether there is a blood clot or aneurysm or anything wrong. And imagine findings and clinical criteria to maximize patient's recovery. So with this we can have a proper recovery process for the patient. We can save the life. Now, it's not a one-person job. Multidisciplinary approach is always mandatory. So in this, a multidisciplinary team, including neurologist is the must, neurosurgeon, radiologist, and nurses is essential for effective thrombectomy planning and execution to ensure optimal patient care. So it is in team. We cannot say that person is on leave, the doctor is on vacation. We cannot do that. There has to be some doctor has to be locum. If such patient comes, then we have to treat, and there has to be some management team. Next one. Now recognizing the stroke with fast. So here we can see the face, typical face of here. The model was not able to do because she is not a stroke patient, but you can see the stroke patient actually looks like this. So face drooping, how we'll recognize? Ask the person to smile. He may not be able to smile. Look for unevenness. You can see when the patient is smiling, you can see both the cheeks are stitching to one each, both the side. But in this case, only one side patient may smile. That side, one side may droop. This is a critical sign of a potential stroke requiring immediate action. Please don't ignore. If you find in the ward, immediately inform to the doctor. Next one, arm weakness. You may say that you have done something, you have pulled one bag or luggage bag, or you are holding some bag and you are saying my hand is because of that, but don't ignore it. Do some testing. Just get it done. Just ask doctor to examine for you. Like examination has to be done immediately. Observe the weakness or inability to lift one arm, indicating possible stroke involvement on one side of the brain. So it has to be identification and smartness of your smartness and promptness is very essential in the management of these strokes. Next one. Now, speech difficulty. Check for slurred or unclear speech. Ask the person to repeat a simple phrase. Simple, what you'll ask, what is your name? Where you are now? Or from where you have come? Like, you can ask simple term and then see what they are speaking and see what is their coordination of what you are talking. Then, necessitating urgent medical intervention, you can find out. Speech is over. Next. Now recognizing again in that balance assessment, be fast you are talking about. So we'll see the balance assessment, evaluate for sudden loss of balance or coordination. This can indicate a potential stroke. There are the chances potentially they may get such type of stroke, requiring immediate medical attention and further assessment. Now eye function check. So eye function, we have to check vision, assess for vision problem such as blur or double vision. Sometimes they may say double vision. So double vision means immediately you have to identify it can be what, like it may be stroke. Okay, and these symptoms can be critical in identifying a stroke. So these symptoms, if you understand, at least you can give proper history or over to the doctors or your seniors so they can take the action. Facial drooping, check for facial drooping similar to FAS. Ask the patient to smile. Asymmetry may indicate a stroke. Asymmetry means only one side, I mean both the sides are not equally straight, necessitating urgent intervention. Now identifying strokes mimics. Mimics means what? Mimics. एक किसी का इमिटेशन करते हैं ना बिहेवियर का. सिमिलर वे समटाइम ऐसा होता है कि वो हम लोग जैसे बोलते हैं डिफरेंशियल डायग्नोसिस काइंड ऑफ मिमिक, कि हम लोग ऐसा हाँ उसका भी हो सकता है, लाइक मिमिक्स. सो सीजर एंड स्ट्रोक, समटाइम पेशेंट को सीजर आएगा एंड यू विल अंडरस्टैंड अरे वो स्ट्रोक हो सकता है, लाइक मिमिक्स. We can understand something else for this. So seizures and stroke symptoms, in that seizure can present with sudden weakness or confusion. Mimicking stroke, a throughout patient history is essential to differentiate between the conditions effectively. If the patient is having stroke and seizure also, if you are getting in history, the patient had a history of seizure, then that you have to evaluate accordingly. Then hypoglycemia symptoms. Low blood sugar can cause confusion and weakness similar like a stroke. It is a similar characteristic, symptoms you can see. So always check blood glucose level in patient presenting with acute neurological deficit. So if anybody is not able to, if a patient is having weakness or stroke, immediately check for the blood sugar. It may be because of hypoglycemia and you will misinterpret it may be stroke. Then migraine aura confusion. Migraine auras can mimic stroke symptoms. Sometimes that will similar with the stroke, including visual disturbances and weakness. Consider the patient history of migraines to avoid misdiagnosis. So migraine, if patient is having migraine and stroke, it will be mismanaged. Diagnosis may happen. Now intoxication of effect. So intoxication of effect, if the patient is like alcohol or drug, intoxication can lead to confusion and motor deficit. So you have to find out if the patient has taken alcohol or some tobacco chewing or some taking non-medical drugs like cocaine and all. So mimicking stroke, always assess the substance used in patient presenting with acute neurological symptoms. So that we have to tally with what the patient is giving the history. And then we can come to the conclusion, really patient is having stroke or not. Next one, emergency assessment protocol. Initial assessment steps begin with vital signs and a thorough neurological examination to establish baseline health data. So to know the baseline health data is very important, and don't see that mimic what I told you. Don't just assess blood sugar, BP and then come to your conclusion. This initial assessment is crucial for determining the urgency of intervention, how it is urgent, but your 60 minutes you have to remember in your mind. Next one. Now NIH stroke scale uses that you must know. Please keep in your mind. NIH means National of Health Sciences stroke scale. Everybody must aware about this. Like NIH stroke scale uses, utilize the NIH stroke scales to quantify stroke severity effectively. How we are having ABGA score? based on how we are seeing abgar kitna hai uske upar accordingly we understand how the baby is at risk. Similar way NISS stroke scale you please keep in your ICU. So if you are finding like this and total you can do it and you can give your presentation to doctor. Okay, so in that this standardized tool helps in assessing the patient's condition and guiding treatment decisions. So if you see these national guidelines, what they are saying, awareness, consciousness, coordination, language of speak, movement and senses. For this they are given the stroke. 0 to 5 means mild one, minor stroke. 6 to 15 means moderate stroke. 16 to 20 again moderate to severe stroke. And remember about 25 to 46, 42 is the severe stroke. So it is very mandatory. Please keep in your ICU this type of stroke. This is as per the new guideline of 2026. Next one. Now emergency assessment protocol, in that I spoke with you, MRI and CT scan, these are the two important tools for the assessment of stroke. So make sure that your CT scan is free, it will not be blocked with the other patient. When you come to know patient is in the casualty and you have to shift the patient to the NRI CT scan, make sure that it is immediately shifted to that and see that that room is empty for the patient. So a CT scan is essential for differentiating between ischemic and hemorrhagic stroke. There we can really see with assessment we may go wrong, but with the CT scan or MRI you will come to know what is happening exactly, whether there is a blood clot or there is any arteries rupture or burst. We are getting the exactly root cause of it and then we can act upon it. So rapid imaging can significantly influence treatment pathway and patient outcome. Next one. Now thrombolysis pathway for stroke management. Now start point, if you see the red button, start point is what? Assess patient. You have, as a nurse or doctor, we have to assess the patient. We have to find out whether there is a ischemic stroke. Ischemic if there is any blood clot. So if it is there, yes, then administer thrombolysis. I spoke just now with you. I spoke with you. Then if no, then consider alternative. What if there is no clot? Then what is that? There may be some occlusion in the large vessel. So we have to send a patient for CT scan or MRI, and we can do other treatment, alternative treatment. And then end is there is the white is the end point. Next slide. Now here's critical impact of timely stroke treatment. Now here you will understand 30% reduction in disability. If you quickly do this procedure, we can 30% reduce the disability. Early treatment can decrease the long-term disability by nearly a third. 3 hours optimal treatment window. Patients treated within this time frame experience significantly better recovery rates. And 50% improve outcomes. Thrombectomy can enhance recovery in half of the patients treated. So they say thrombectomy also is the major accurate method where we can save the life of such patient. Next one. Now post-stroke care consideration, importance of rehabilitation. Now here after doing this also sometime 20 to 30% patient may get paralysis, patient may be bedridden. So what we can do? Importance of, then there is the importance of rehabilitation, like physiotherapy comes into the picture. So rehabilitation is a crucial role for stroke recovery, with studies showing that early intervention can improve functional outcome by 30% with the first 6 months. We can see first 6 months we can really recover such kind of patient. I have one case with me when I was in Kokilaben hospital. Usha madam must be knowing. We were having that time principal Dr. Upasini madam, and her relative, she got the aneurysm. Previously she got the stroke, and after aneurysm, Dr. Tiwari something, he has removed his that aneurysm. After that, within 3 months, I have seen with the physiotherapy, she improved a lot. And they were having nice, in Kokilaben hospital, we were having the nice small units. Like if in recovery process, how she will go to the kitchen, how she will hold a glass, how she will light the gas, and how she will walk up, how she will walk down. There is a mini structure, it is there in stroke management unit in Kokilamin Hospital. So that they have done, and she recovered within 6 months. So rehabilitation has really effective for such kind of patient. If we can improve and we can save their life. And now she is really fine. She's doing her own activity independently. So you can see such physiotherapy has a major role in treatment of this. Monitoring for complications. Patients are at risk of complications like aspiration pneumonia, because if they are not able to swallow, drooping of face, they cannot swallow, then they may have this aspiration pneumonia within which occurs in 20 to 30% of stroke patient, necessitating vigilant monitoring and timely intervention is required. That will be done by us as a nurse, a first person who is with the patient. Patient education on lifestyle. Now lifestyle is more on a bloom, like everybody wants to do modification on lifestyle, but you have to really initiate from yourself and move yourself, and then you can move your family and your friend circle. So lifestyle is not only eating good or bad thing, but you have to be mobile all the time. You cannot sit at one place. You have to mobile. After food you can mobile 15 minutes, after breakfast, lunch, dinner. You have a proper sleep, sound sleep. ऐसा नहीं कि मैं 2 घंटा सोई 3 घंटा. No, you must have proper sleep. Sleep will increase your cortisol level. There are so many things here. There will be separate lecture we'll have in CPD lifestyle modification. But here just I want to say, your sleeping pattern you have to change. Sleeping is the main thing where your body structure or body mechanism will go wrong. So you have to have a sound sleep, proper diet, don't eat outside. It is what you can say, these are the thumb rule. So you have to please modify and do exercise. It's not only to go to the gym or go for the walk. There are so many nitric oxide exercises are there that you can do in your bedroom, toilet, wherever you are doing, you can do that nitric oxide exercises. If you are having lunch time, you can just do 5-10 minutes. Every day 10 minutes, so it will really help you out. So there will be mobility of your body parts. Next one. Now future direction in stroke care. Telemedicine. Now we are coming to the prevention and management part. In that, telemedicine is revolutionizing stroke care for providing remote consultation. So here many government, madam may tell us, government facilities are there. They are sending all the doctors to the rural part. I think there is a rule. Those are new doctors, they will work first in the rural urban area, then they will work in the urban area, because nobody wants to go to the rural area. So telemedicine, we are reaching to the remote countries, remote places. Improving access to specialists and reducing time to treatment, and especially in rural areas. Telemedicine has a most important part in it. Then AI in stroke management. Artificial intelligence is streamline diagnosis and treatment in planning. Definitely AI will help you in planning process, with algorithms achieving over 90% accuracy in identifying stroke types from imaging data like CT scan and MRI. Continuous education importance. Ongoing education for healthcare professional is crucial, with programs focusing on the latest stroke protocol and technology to enhance patients' outcome. So you must know the new guidelines and protocols with you in your department, then only you can save life of the patient. See, research on the new therapies. Research into innovative therapies such as neuroprotective agents are coming up. They are there in the society, and they are using in big hospital. Every hospital, I think they are using this neuroprotective agents and advanced thrombectomy techniques. Now, advanced thrombectomy techniques are very easy. Within half an hour, you can remove that clot and you can save the patient's life. Because golden hour, we have to remember 1 minute, 60 minutes. This, because of they have done various research, they can do within 10 minutes or 15 minutes, they can remove the clot and save the life of the patient. Aiming to improve recovery rate and reduce the disability. Next one, stroke management guidelines 2026. It is there, available everywhere. So thrombolysis and medication updates, they are saying you can start tenactip plus preferred, that is tenactip plus single IV bolus 0.25 milligram per kg, maximum 25 mg is fully endorsed as a practical non-inferior alternative to altiplase within a standard 4 to 5 hours in window. Extended window up to 24 hours and no adjuvant thrombotics. So they said we have to check whether the patient is on heparin or not. Then DAPT for mild stroke. So DAPT is what? Dual antiplate therapy. And aspirin and clopidogrel is preferred to prevent recurrence. So these are the two good drugs what they are mentioning. And extravascular thrombectomy, that is called EVT, extravascular thrombotomy expansion, large core or disability selection. In that they says that eligibility for mechanical clot removal has expanded meaningfully to include patients with pre-stroke disability and those with large ischemic cause, aspect scores of 3 or greater. That is for doctors. Then, and they initially they say no unnecessary delay. You have to be quick enough. Next one. Post reperfusion and general supportive care. You have to discipline blood pressure management properly. Relax glycemic target. Relax, there is a glycemic target also they have mentioned. Intensive blood glucose control targeting 80 to 130 is rejected due to severe hypoglycemia risk. So what they are mentioning, less aggressive management, maintaining level between 140 to 180 is low preferred. So they have given in this line. Then first ever pediatric guidelines, what they are mentioning, for the first time the document features official consensus and data-backed guidelines regarding acute stroke recognition trials and safe extravascular interventions for pediatric patients. So EVT we can do for the pediatric patient, they are just initially mentioning. So in short, there are so many therapies are coming up and doctors are ready to do, but early recognition is our part, our whole and sole responsibility of ours. So identify such thing and inform to the doctor. It is mandatory. Next slide. So highlights of these presentations. In summary, effective stroke recognition and management hinge on differentiating ischemic and ischemic from hemorrhagic stroke, because many doctors get confused with if they don't get proper baseline data or don't get proper X-ray CT scan report, they may confuse with ischemic or hemorrhagic stroke. Utilizing be fast for assessment and understanding stroke mimics. So stroke mimics also you have to understand what I mentioned. It may be hypoglycemia, you may say that usko stroke aaya, aisa nahi karna hai. If the patient got stroke and high BP is there, so you have to see first BP क्यों hai. Like you have to see the underlying cause. Don't directly go for the stroke. Nurses should prioritize online education and collaboration with multidisciplinary teams to enhance response time and treatment efficacy. Together, we can significantly reduce the impact of stroke on our patient's life and promote better recovery outcomes. So here, with positive note of the stroke management, I'm ending with my session. And I just want to just declare one thing. Something in future plan, I just spoke with the madam, Dr. Vidya. I just spoke with her ki the Riddhi Vinayak College of Nursing, we are having med surg department, we are having 3 to 4 faculties from the medical surgical department, and we will decide, we will plan a stroke unit run by the nurses. Like it is my dream. So we can train our 2 nurses, those are pass out, and this supervisor, these seniors, thank you madam, these seniors will see if they have such patient, they will tackle over there. Even Sister Cecily and their team is their ICU staff. We can have a team of stroke management. We can open such type of unit so we can save the patient's life, and we can do, and our hospital also worldwide recognized. We can have the multi-speciality like a stroke management unit we can open, run by the nursing college staff, or like something guidance, under their guidance we can run that, and we can do the best of it. So that is, we can have various protocol guidelines in that unit, and we can really take care of such patient, those who require help. And we are having very good physiotherapy department, ICU. We have all ICU nurses, those are very expert in treating the patient. So if you start a stroke unit separately, we can achieve many milestones of our college. Thank you, madam. And with this, I will end of my session. Thank you. I will hand over this mic to Miss Sudha.
Thank you, ma'am, for highlighting the informative session. Your insight have reinforced a crucial message for all the healthcare professionals. Recognize the sign, respond in time, save the brain. Let us express our appreciation with a round applause. Yes, there are some questions also. So first is, what are the first steps in the stroke assessment? The first step include using the fast and brief-fast method to quickly identify stroke symptoms, followed by rapid neurological examination and imaging to confirm the diagnosis. How do we differentiate between the ischemic and hemorrhagic shock? Differentiation is primarily done through imaging such as CT scan, which can reveal the presence of bleeding. For hemorrhage, stroke or lack of ischemic strokes. What are the risks of thrombolysis? The main risk for thrombolysis is bleeding complications, particularly intracranial hemorrhage, which can occur in about 1 to 6% if it is not treated in the patient. When should we consider thrombectomy? Thrombectomy should be considered for patients with large blood vessel occlusion who present with a specific time window, typically up to 24 hours, and prevents salvageable brain tissue as determined by imaging. Thank you.
So now we'll be continuing the next session. Stroke recovery is not limited to restoring physical movement. A survivor may also struggle to communicate, think, remember, express emotions, and reconnect with everyday life. Therefore, restore communication, rebuild confidence, reconnect lives. Our second session is on communication, cognition, and psychosocial care after stroke. To take us through this important dimension of holistic stroke care, we have Professor Miss Usha Menon, ma'am, Vice Principal of Riddhivinayak College of Nursing. It's my pleasure to introduce Professor Usha Menon, ma'am. Ma'am holds a master's degree in pediatric nursing and has also completed a postgraduate counselor course from the Tata Institute of Social Sciences. She has 15 years of clinical experience and 20 years of teaching experience. We welcome her with a warm round of applause. I respectfully invite Professor Miss Usha Menon, ma'am, to begin the session.
First of all, a very good morning to all of you. I'm sure all of you are very tired after listening to such an in-depth and useful and very heavy session from our Dr. Oak Madam. Very important and very in-depth, and yes, those are the basic things we must know, and based on this, then the next step comes is the psychological, emotional, all those aspects. But before going that, I feel that we are the lucky one to be here today to attend this program. So let us clap for ourselves. Yes. Before beginning the session, let us remind ourselves. Look into within, from your mind, आपके मन से देखना है, आपके forehead में जहाँ आप चंदन लगाते, टीका लगाते, वहाँ पे focus करिए और अपने आप को देखिए और बोलिए कि हम वो चैतन्य शक्ति है. We are that energy who is in charge of our body, who is making us to talk, to listen, to hear, do the activities, everything. We are those energy and we are in command of our body activities. And very important, our thoughts. ये हमेशा अपने को दिन शुरू होने से पहले और रात को सोने से पहले याद दिलाना है कि हम actually कौन है. We are those energy who are in charge of our body and who has come to this planet to do our role, play our role in a like a hero and a heroine, okay, to play a role in a positive manner. ये हमेशा याद रखना है. इससे क्या होता है, अपना दिन बहुत अच्छा जाता है. All right, so I welcome you all once again and let us proceed with our second session, a very important session because जो लेमैन है वो जितने भी अभी हमने हेवी वर्ड्स देखे, डायग्नोसिस, ट्रीटमेंट या जो भी था, इमेजिंग, ऑल दैट MRI स्कैन, ये सब लेमैन को समझ में नहीं आता है. What he or she will understand is how he or she is able to communicate, how the nurse is trying to help out, whether it is physical help or even emotional help. But the main thing is, it is not the caretaker that is very important. It is a family support that is very important, remember, in this aspect. So today, in this small session, it will be a very small session related to the communication, the cognition, and the psychosocial aspect. Remember, stroke is not something like a fever or something that you can cure and we can, come out of it within a few time period. No, it is a very lengthy aspect and the rehabilitation is very, very crucial. So as already Madam has said and has informed what is stroke, we will just see how and what it is. You all are able to see it very clearly over there. It is definitely an emergency condition because the blood flow in any of the brain aspect is being, either it is blocked or it bursts, the blood vessel will burst. And then therefore, outwardly, physically you will see certain aspects. Maybe there is a disturbance in the facial symmetry, as Madam has already said. Maybe there is drooping of the face and also the saliva is also drooling out, yes, and may not be able to smile or even the speech will become very slurred. कुछ कहना चाहते हैं, उनको पता है उनको क्या कहना है. The intelligent is not being hampered. Okay, so whatever they're going to say, be it a single word or a sentence, it will be so slurred that the person who is there taking care of the patient is not able to understand कि भाई वो क्या कह रहे हैं, because it is very slurred. You understood? Because the muscles and the muscular region and all this aspect related to the speech, that domain is being disturbed because of this blood clot that is present in the brain region. So if you find the patient is having any left side deformity or weakness, that means the right side hemisphere of the brain is being impaired. Okay. Similarly, if you find the patient having on the right side the weakness, that means the left side of the hemisphere of the brain is being affected. Very simple to understand. Yes. So in the medical aspect again, इसको हम लोग cerebrovascular accident भी कहते हैं, ठीक है. इसके अंदर again two types बताया गया है, ischemic and hemorrhagic. Hemorrhagic, the word itself is saying when there is some bleeding. That bleeding occurs because of the bursting of the blood vessels in the brain. And ischemic could be due to the blood clot that is present in the brain domain. बहुत challenging है taking care of stroke. लकवा कहते हैं ना, paralysis. It can be hemiparalysis, it can be paralysis of the whole extremities. Very, very challenging. किसके लिए है भाई challenging? The person who is suffering and also the person who is going to look after them. Is it the nurses? नहीं नहीं, nurses हमेशा थोड़ी रहेगा. Nurses will be present until the time the person has come to the nursing home or to the hospital for their treatment. But after that, the biggest challenge is taken by the relatives, or should I say, significant others. It can be anybody who is very near to the next kin of the person who is suffering with this particular damage to their brain. It's a very sad thing. Here, the person will feel, I'm not able to say anything, I'm not able to do my daily activities, I'm not able to even, show my feelings, my emotions I'm not able to control. Maybe I'm sometimes getting very angry, or maybe I'm only all the time in tears, I'm not able to control. वो सोचते हैं, what is wrong? So what is happening? Their confidence level will go down. And if the relative will also get tired and fed up, because patients se zyada, it is the relatives who need the strength and the energy and the will to go further. इसके लिए मैंने शुरू में कहा था, अपने आप को देखो और सोचो कि हम कौन है असल में. We are not this body. We are using this body to take care of a patient. और इसको patient तो नहीं कहेंगे. It is my beloved who is in one of my family member who has endured this particular sadness that is in the life. So it is a very, very time consuming. So you should be very patient. आप में अंदर वो सब्र होनी चाहिए. कळलं ना? You cannot say चला चला पटकन आपण बरं होऊया आणि पटकन घरी जाऊया, चला चला तर उभे राहा. No, that will not happen. That will demotivate the person who is suffering, and it will go into, and many a times if such the torturous way of handling by the relatives will make the person to go into relapse. Second lakwa aa jata hai, and that will become very fatal, totally bedridden. I've seen such cases. So it's very, very challenging. So as rightly as said, Madam has said, which are the aspects? The cognitive domain is being affected, the communication aspect, that means the speech is being affected, and then, very important, the feelings and the emotions aspect are also affected. You understood? And ultimately, the physical aspect is, because my limb is being affected, I'm not able to, even point to someone, I'm not able to, even to hold a glass, I'm not. My daily living activities like brushing my teeth, combing my hair, nothing. So my physical aspect is also affected. So these are the greatest challenges that we, the patient also, and the person who is helping. It may be the caretaker or the family member, as I've said. So it's a great challenge. Okay. So here when you want to diagnose, very, very rightly Madam has said already, the MRI, then the neurological assessment, and the CT scan, all this will there along with the physical assessment of the patient. Ani, remember, there are multi-modalities or therapy that is required if you want the patient to be coming out of. It is a long duration. So when you talk about rehabilitation, please keep it in your mind. म्हणजे पुन्हा, habilitation म्हणजे पुन्हा त्यांना सोसायटीमध्ये जसं होते तसं एक युजफुल कम्युनिटी मेंबर म्हणून सर्व्हिस जर त्यांना करायचं असेल, जगायचं असेल, तर we cannot come back to as we were before. So please, there is an important word that you need to underline when you say about rehabilitation. That means bringing back the person to the near normal of life. तर त्या near normal ला जरा तुम्ही underline करा. We can never become normal once that particular defect, maybe it was paralytic attack, maybe it was a fracture or whatever. Okay, so what we can do is we can come back to the near normal, so at least we are able to do our ADL, that is activities of daily living. Okay, so this is very crucial, and here certain aspects of therapies are being shown, say like occupational therapy, physical therapy, that will include both active as well as passive range of physical therapy of our body, and cognitive rehabilitation, because here the brain damage has occurred, so the patient is not able to reason up. The function of the brain is impaired, so he's not able to take a logic reasoning. He's not able to even think of further, ki काय करायचं आणि काय आहे, because that domain is being impaired, okay, damaged. And definitely the physical therapy has to be done. Either it can be done by the nurses or by now we have all physiotherapy departments, so they are the one taking over it. But in my time, I remember as a GNM student also, we used to give active and passive body movement extremities for the stroke clients when I was a student in BYL Nair Hospital. I remember those days. We used to do that also as a nursing student. Then of course, a task-specific training. That means how to speak, how to hold a glass, how to stand. Again, as though we are reteaching them and the patient is relearning all that one by one. It's very, very important, okay? But remember, when you're going to develop or teach them again related to the speech therapy, the communication aspect, it requires so much of patience, so much of pace, or you cannot hurry them. And neither the patient should be in a hurry. म्हणजे त्यांना वेळ लागतो आणि आपण पण त्यांना ते वेळ दिली पाहिजे. कळलं? So we cannot hurry up. If they want to utter a word, they may take time. It's all right. You can be patient enough. You maintain the silence till that person is able to grasp or verbalize it or say it. So that kind of therapy is being provided. Therefore, the stroke rehabilitation aspect is very, very important. Many a times it will go till 1 year, even sometimes even 2 years of rehabilitation period. Okay, because right from how to walk, how to talk, everything has to be done again. So we will see that stroke rehabilitation involves specialized care targeting the language impairment, also called as aphasia, and dysarthria, cognitive deficit, which includes memory and the executive function, and psychosocial struggles like they may go into sadness, low confidence, therefore landing into depression. So here the key areas, speech and language therapy, the cognitive rehabilitation and the psychosocial support is very, very important if they want to regain their life as they were before. म्हणजे लक्षात ठेवा, near normal. आणि well-being of their mind, the mental peace, the mental stability, the well-being of the mind, and then that will come to the well-being of the body. So these are the most important challenges that we need to face. Even the patient has to face this patiently. तो वो धैर्य होना चाहिए उनके अंदर, वो time होना चाहिए. Yes, we can do it together. We will there, and we are there for you to support. असा हा जो एक feeling आहे ते त्यांनी relatives नी पण दिली पाहिजे आणि caretaker नी पण त्यांना दिली पाहिजे. So we will just see what is the meaning of aphasia, that the word that we had used in the previous slide. So it is a neurological language disorder that impairs a person's ability to speak, understand, read and write. So it does not affect the intelligence. As I said before, they know very well what is the sentence that they want to say, but because of the slurredness of their speech, they are not able to verbalize. So it is typically caused by the brain damage from either from a tumor or from a stroke itself, or maybe some traumatic brain injury. Then there was another term, dysarthria. This is a motor speech disorder caused by nervous system damage that will weaken or even impair the control over the muscles that we are using to speak, that the muscles which are used to speech. So it results in slurred, as I said. Slurred म्हणजे जे काय म्हणतात ना ते, it will be not able to pronounce it properly because the muscles are being affected. You understood? So if they may say bus, इतना ही बोल देंगे, the caretaker will understand. They are asking for water, or they are asking कशी आहेस तू. When the relatives come, they want to smile, but they are not able to smile. देखो कितनी उनके मन में विडंबना है. You understood? So all that we should know, that empathy aspect has to be there in our nurses. Then we are able to take care of them in a positive manner. You understood? So it is a dysarthria is a motor speech disorder caused by nervous system damage that weakens or impairs the control over the muscles that is used for speech. So it results in slurred, slow, and difficult to understand speech. Though the person typically knows exactly what they want to say because their intelligence is not impaired. Karla ka? Understood? So here you see how in a hospital setting or in a nursing home setting, the nurses are providing, or even you can say it is the physiotherapist who is there providing the physical activity with the help of a walker. And I suppose the left arm is being impaired and not able to, therefore that assistant is helping by giving support to that extremity, if you notice. Yes. So here the patient and the caretaker both have to be very, very patient. त्यांना ते perseverance असलं पाहिजे की पटापटा करून जायचं मला अजून 10 patient आहे. No. You have to give them ample of time. They may take for one step, they may take 5 minutes. It's okay. It's all right. Therefore they are there for the rehabilitation. Again, let me remind, stroke rehabilitation, bringing back to the near normal. Please near la underline karun taka. Okay. So, stroke rehabilitation, post-stroke, the interconnected nature of the communication, the cognition. Cognition यानी the thought process, you know, आप जो knowledge aspect जो है ना, cognitive domain, that, and emotional. Okay, this health, all this will dictate that the care must be holistic. Ha word ऐकला असेल ना तुम्ही? It means you are giving a comprehensive care where all the physical, the emotional, the social, you know, all these aspects of care are being given together in one time. At that time it is comprehensively provided, therefore it is then labeled as holistic care. And then spiritual aspect is also there. Spiritual aspect म्हणजे असं नव्हे की मी जरा भजन केलं किंवा चर्चमध्ये जाऊन एल मेरी सांगितलं, नाही ते नव्हे. Spiritual aspect is really who you are and why you are here. What is the purpose of you? Understanding the wisdom that you gain, that time it is labeled as your spiritual aspect. So that spiritual enlightenment during such disaster like in the stroke and all, really it helps to recover fast. You understood? Then successful case management will definitely involve the interdisciplinary rehabilitation. Interdisciplinary, again holistically, that means speech language pathology, the occupational therapy and the psychology. All this has to be together, and then these will adapt this theory, these therapies to address their speech, that is a language deficit, because they are unable to speak because the muscle is being involved. Okay, that is aphasia, and the cognitive impairment, the thought process or the function to think and reason is being impaired. Okay, therefore that is called as executive dysfunctioning. And of course, based on all this, my emotional aspect, my psychological aspect is also definitely impaired, and I need to have well-being of that simultaneous along with my physical therapy. Okay, so this holistic care is a big challenge for the nurses, also for the caregiver also, and for the caregiver of the relatives, you know, those who are there involved. Therefore, whenever you are, you know, giving care to such patients, please see to it that you are actively and allowing the patient's relatives to participate in the care. Also, whenever possible, allow the patient also to actively participate in his or in her own care, so that he or she will feel useful and can gain the confidence and will be able to go ahead thinking, oh yes, I can do it again, I can come out of it. You understood? That aspect is very, very important. So here you see how the nurse is teaching the person again how to write, how to hold the pen, how to, you know, spell it out, how to pronounce, how to speak. Again, see, which the left hand I guess is impaired, and then the assistant is holding it and helping. So what are those key elements here related to the stroke care management? First and very, very important, communication, rehabilitation, then of course the cognitive management and the psychosocial and the emotional support. Okay, this is very important. Clear? Understood? Easy hai na? But mind you, easy hai utna hi difficult to implement it. You understood? There are certain aspects, because it is multimodality सांगितलेला आहे. That means First and foremost, the person should not feel, "Arey, I am good for nothing, I'm not able to do anymore, this is the end of it, bas, ho gaya, khatam meri story." No, if that is there, they will become self-critical. Suppose if they are able even to hold the comb, समजा त्यांना केस विंचरायचं आहे आणि त्यांनी फणी काय कंगवा असं जरी धरलं ना, you have to immediately encourage them, "अरे वा, very good, what a good process, now you can hold your comb." So that will give them the encouragement, "Oh yes, I can do it." Then you may hold the mirror and let them give one stroke on their hair. So slowly, slowly, they will learn how to comb my hair and how to maintain my grooming. From there, the basic step you need to start. So every step you need to give the reinforcement of positivity to them. Then only they'll be able to go ahead and their self-critical attitude will go away from them little by little. And very important, they will be attending the therapy session. It can be either individual therapy or the group therapy session with the family or with other cases who are having the similar cases. Okay, with similar case patients, they can have a group therapy. Whatever is available in the organization accordingly. But that attending those sessions are very important to keep up the morale. Morale म्हणजे ते आपलं ते dignity असतं की नाही, ते आपल्याला नेहमी वाढवलं पाहिजे. नाही तर हळूहळू खाली खाली गेलं की then we will demoralize and we will get demotivated and our confidence level will become zero. That's very, very important. Then you may tell them to maintain a diary or a journal, to write down certain aspects, slowly, slowly. So they will also learn how to hold a pen again, how to write the words, the alphabets, they formulate a sentence, whatever. And because the memory is impaired, it will help them to keep in mind की बाबा मला हे 4 वाजता हे गोळ्या घ्यायचं आहे किंवा हे झोपायचा वेळ आहे काय असेल ते. So they are able to, the memory thing is also being restored if they'll write it down, pen it down in the journal. Yes, and very important, physiotherapy, active and passive. Physical involvement is very important. Every day, at least 4 times a day, if they are undergoing the physiotherapists, if they even do the home visits. If my patient is at home, we can call them and the physiotherapist can come home maybe twice or thrice a day, and then they will give the required help. See, here you will see how in the physical therapy department, the patient is being helped. The affected limb is being supported by the therapist, and slowly that physical, you see, by lifting some dumbbells or whatever, weight lifting something, all this is done for the physical curing along with the speech and the emotional aspect. So remember, stroke rehabilitation will take time. It is not that within 6 months I can go home or like that within 1 year I can, no. It may even last up to 2 years. So it's very, very important and challenging for both the patient and the relatives and the caregiver. So here we have seen that in the cognitive aspect, in the speech therapy, which are the aspects that will be, impaired and required attention. That is your memory aspect, then your concentration or attention aspect, then what you're going to implement, what are the reasoning or the steps that you're going to take for XYZ, activities, and even your basic problem solving aspect that is also being impaired. So these are the aspects that will be included when the therapist is going to deal with the speech therapy for the patient. Of course, it will include the language and the communication aspect. This is a very, very important region, and this will also take so much of time. We cannot hurry up. We have to give them the pace, P-A-C-E, pace and the time. Okay, we cannot hurry up, neither the patient need to, otherwise they will get demoralized. Please keep it in your mind. It's very, very important. तर आपण पुन्हा पाहूया की stroke rehabilitation मध्ये first and foremost the communication care is given. So here the communication disorders affect a significant a number of the survivors. Survivors म्हणजे ज्यांना हे लकवा झालेलं होतं आणि ते पुन्हा त्याच्यावरून ते बाहेर येण्याचं रिहॅबिलिटेशन ऑकर्स. ओके, दे आर कॉल्ड ॲज सर्वायवर्स. सो एफएसिया म्हणजे इम्पॅक्ट स्पीकिंग, अंडरस्टँडिंग, रीडिंग आणि रायटिंग. दीज आर द ॲस्पेक्ट्स दॅट विल गेट impaired or affected when you use the term aphasia. So it is addressed through intensive speech therapy, targeting word retrieval and functional communication. तर ह्याच्यात काय त्यांना इवन सिंगल सिलेबाय किंवा सिलेबस वर्ड्स सेंटेन्सेस ते हळूहळू त्यांना परत परत ते मिरर समोर ठेवून त्यांना ते स्पीच थेरपी शिकवतात आणि इट इज व्हेरी चॅलेंजिंग. इवन इन आवर KDA वी हॅड दिस स्पीच थेरपी डिपार्टमेंट. इट्स व्हेरी ब्युटिफुल डिपार्टमेंट. हियर द पर्सन हॅज टू बी द केअर गिवर हॅज टू बी व्हेरी व्हेरी विजिलंट अँड पेशंट. त्यांना ती धैर्य आणि ते वेळ असलं पाहिजे त्यांच्याकडे, जेणेकरून बिकॉज द मस्क्युलर रिजन दॅट इज रिक्वायर्ड टू स्पीक इज बिंग इम्पेअर्ड. देअरफॉर इट्स नॉट इझी. दे विल नॉट इमिडिएटली से इट आउट लाईक अ पोपटासारखं सांगून पुढे जाणार नाही. इट विल टेक सो मच ऑफ टाइम. सो यू हॅव टू हॅव दॅट काइंड ऑफ पेशन्स. Then only the patient will have faith in you and will try to come to your department every day for such therapy, speech therapy. Then the next is dysarthria and aphasia. This involves muscle weakness affecting speech clarity. Speech clarity बघा, जेव्हा ते slurred speech असतं तेव्हा clarity नसतं. The caregiver will not understand what the person is trying to say. You understood? So here the therapist will focus on the oral motor exercises. Even the how to breathe, the breath controls is being taught. आणि कसं breathe in, pause, breathe out. So there is some kind of pacing, some space is there, you see. असं फट breathe in, breathe out, nahi. That is there is slowly they will inhale and exhale. All that kind of exercises are being dealt when they are the speech therapist is going to tackle such cases. And very important, the practical strategies. Strategies म्हणजे the planning we need to do. की बाबा आपल्याला पुढं काय करायचं आणि कसं आणि how it will help the patient. You understood? So here the caregiver should present one idea at a time. एका वेळेला फक्त एक गोष्टी. You understood? You do not say multitasking का जमाना है चलो चलो multi. No. They will handle only one thing at a time. Therefore, whatever the other things are there, you can minimize it. Maybe it is the background noises, minimize. Maybe the light is too bright, minimize. If there are any sharp objects, if the person is trying to walk around, maybe a table, chair which is there obstructing, remove. Okay. And therefore, you will provide ample response time. परत मी सांगते, ample response time. धीर धरायचं. कळलं तुम्ही? मग ते पेशंटला त्यांना असं खात्री येणार, they'll get trust on you. You understood? And therefore you may use certain aviates also. Okay. So that they will remember की हा मला हे करायचंय किंवा हे बोलायचंय. And there can be various communication aids, maybe with the help of a calendar, or as I said, they can write it down in their journals. You understood? So these are the aspects when it comes to the communication care related to the stroke management किंवा stroke rehabilitation. Then very important, cognitive domain. Cognitive मध्ये मी सांगितलं होतं thought process, yes, and the whatever cognitive functioning. मला काय कार्य करायचंय, कसं करायचंय, how will I give reasoning, how will I use my problem solving process, all that, so and so forth. These all are impaired because my memory is also damaged, no? There is impairment in my memory also. Therefore, in cognitive rehabilitation, the caretaker will see that it's a very, very challenging aspect because there are memory loss. Therefore, my concentration and attention also is lost. So it is impaired. I am not able to, there is a deficit. Deficit म्हणजे कमतरता आलेला आहे. म्हणजे I am not able to focus even for 1 minute, even for 5 minutes. Forget the hours. You understood? So this is very challenging for the caregiver. And then how I'm supposed to, suppose माझा केस विस्कटलेला आहे. Just a small example. मला ते कंगवा टेबलावरून उचलून असं घ्यायचंय आणि असं कंगवा करायचं. It's a big activity for me because I am having paralytic attack. You understood? So these are all very, very important and it is highly prevalent. And second, any kind of deficiencies किंवा impairment किंवा deficit असेल ते आपल्याला address केली पाहिजे. So इथं caregiverनी खूप alert राहिलं पाहिजे and therefore the working memory, the problem solving and the task initiation and very important, impulse control. I told you, patient may get very angry and will start shouting at you or may even start crying and there is no stopping to it because there is sort of emotional diarrhea bolo. That means patient will become very impulsive, is not able to control their feelings or emotions. You understood? So what are those compensatory strategies that you will use as a therapy giver or as a caretaker? It will help the person to survive and to use various aspects, aviates like say calendar or journals or any kind of aviates, and therefore the caretaker must see that the environmental, त्यांची जे परिसर आहे त्याला जरा काय काय चेंजेस लागते ते करून दिलं पाहिजे आणि करून घेतलं पाहिजे, otherwise the patient will not be able to keep in memory or will not be able to say or go further. आपल्याला असं वाटत नाही आता अरे काय स्ट्रोक, पण जेव्हा खरोखरच आपल्या फॅमिलीमध्ये कोणाला स्ट्रोक होणार किंवा जेव्हा आपण ते पेशंट जे हँडल करतो तेव्हा आपल्याला त्याची इम्पॉर्टंट कळते. You understood? So please, I hope all of you are vigilant and awake. Nobody is dozing over there behind. And I will ask you question, those who are dozing. And so, very important, mental fatigue management. Fatigue म्हणजे काय? Tiredness. तुम्ही नाईट करून आला, तुम्ही फटीग आहात, म्हणून मॅडम आय एम डोझिंग, प्लीज एक्सक्यूज मी. या फाईन, यू आर एम एक्सक्यूज्ड, यू कॅन डोज अलाउड. तर इथं कसं असतं ते मेंटल फटीग मॅनेजमेंट काय करायचं असतं? लकवा मारलेला पेशंटला, हिअर द थेरापिस्ट is facing a big challenge because the client will say, no more, I cannot take even, I cannot even stand. Forget about looking at you, I cannot even stand. So there is no question of me walking today. They may refuse because they are tired. Are they really tired physically? No, the tiredness is coming from the mind. Their mind is tired, fatigue, म्हणजे थकलेला. When their mind is tired, so their body is also tired. You understood? So survivors will often experience severe post-stroke cognitive fatigue. So managing this involves breaking the task into smaller steps, and while performing these actions they should take periodic break in between. त्यांना वेळ दिली पाहिजे. पटकन कंगवा घ्या आणि परापट तुम्ही केसावर असं फिरवा आणि पटकन बसा, ग्रूमिंग करा. No, that will not happen. Maybe this 5 minutes job they may take 1 hour. It's okay. You give them time break. That's very important and challenging. That will know how much good caregiver are you, even in a nursing home or in a hospital or even as a home nurse. Then the most important, आपल्या सोसायटीमध्ये आता आपण काय बघतो? रिलेटिव्ह कोणाला असं लकवा मारलेलं त्यांना आपण पटकन नर्सिंग होममध्ये फाक असं फेक देते, त्यांना तिकडे टाकतात आणि पटकन तुम्ही पळतात वेकेशन. Arey, let me go, I am also fatigued, my mind is fatigued, let me go. And believe it or not, they may go even out of India touring, leaving that person in the mercy of nursing home. That criminal things are going on in the society now, I'm sorry to say. This is the most important aspect, psychosocial support. You understood? So mental and emotional health is a critical component of the recovery journey, as depression and anxiety will affect a large percentage of the survivors. Samja tumi leaving that person, what that person will see? त्यांना इतकं मी लहानपणे सगळं केले, आता बघा आता मला त्यांची गरज आहे, त्यांनी मला टाकून दिली. So immediately they will go into sadness, depression. And they will be maybe a relapse. Even if they are going to come out of it, they will go back and they will get a second attack of paralysis, and that will be more fatal. Therefore, the person needs to be out of the anxiety. They should always feel, Baba, I have a, like in a cricket game, there are so many fielders around, na? Like that the stroke affected person should feel, ki Baba, mala, maje relatives ahe. चारी तरफे मेरे को लोग टेक केयर कर रहे हैं. दॅट काइंड ऑफ फिलिंग दे शुड गेट. दे शुड नॉट फील अरे मला ह्यांनी दे हॅव अबॅन्डन्ड मी, त्यांनी मला नर्सिंग होममध्ये टाकलं आणि पळून गेले. नो, दॅट काइंड ऑफ फिलिंग विल कम. दे विल डेफिनेटली गो इन टू एन्झायटी अँड डिप्रेशन. यू अंडरस्टूड? देअरफॉर द सर्वायवर्स फ्रिक्वेंटली एक्सपिरियन्स ग्रीफ. ग्रीफ म्हणजे दुःख, सॅडनेस. दो देअर इमोशनल ॲस्पेक्ट there is an impairment, still they will be deprived of the happiness. So they will feel sadness all the while. They will feel frustrated. There will be mood swings. हाँ, जैसे है ना वो फिल्म कभी खुशी कभी गम, like there will be mood swings, and emotionally I am not stable, so there I'll be labile. Sometimes I am very angry, sometimes I am very sad. You understood? So all kind of emotional lability. Lability म्हणजे त्याला स्थिरता नसतं, त्याला stability नसतं. You understood? Then the therapies. हे तर बघा काय काय therapies आहे. Cognitive behavioral therapies ऐकलंय का तुम्ही? Here the patient is taught what to think, how to keep a positive attitude, okay, how to behave thing in a positive manner. ते सगळं शिकवलं जातं. Those are the basic things. That means cognitive behavioral therapy. They say like this. That means your thought process should not go into a negative mode. The minute it goes into negative mode, you will become depressed and anxious. आणि अजून काय असतं? It will help the person to come out of their whatever that damage that has happened, sudden shock, post-traumatic stress disorder has occurred to them. त्यातूनही त्यांना बाहेर यायचं आहे. So this PTSD we see usually among the soldiers, among the military personnel when they go to a war, and then when they come back, whatever cruelty that they have witnessed during the war time in the field, that kind of fear and that kind of phobia remains with them for many number of years, even after when they are in their home, in their peaceful environment. तरी सुद्धा ते तसंच असतं. Same kind of trauma is there even for the paralytic attack patients. Okay. So here the professional psychological support such as cognitive behavioral therapy called as CBT, it will help the survivors navigate post-stroke depression, even anxiety, and can come out of their PTSD. Very important, social connection. आपके एरिया में है कि नहीं पता नहीं, but we do have a corner in every road where the elders and the senior citizens are provided with an area with like a small garden. There are newspapers that is provided free for them. There are swings along, some tea may be served. Why? So that the elderly, the such retired people come along together and they have a chat and sit together. That helps them, that give them a feeling that they are not alone in their old age. Old age is very challenging. And as madam has very well said, old age मध्येच फक्त stroke होत नाही. कधी आता ते pediatric पण त्यांनी mention केली. What a shock. You understood? So here the social connection is very important. Therefore, we need to, the person who is affected, they need to join a community-based peer support network. Peer म्हणजे same age group, okay? And it will help to reduce the social isolation. Isolation म्हणजे आता in Mumbai, it is very common. We all isolate ourselves from, even we are not aware who is a neighbor, what's their good name, what are they doing. We don't know because we are into our own small boxes. जैसे मैच बॉक्स की तरह हमारे बिल्डिंग बने हुए हैं, उसके अंदर घर के अंदर हम बंद रहते हैं. We don't know who is who. So this is very dangerous in such cases. Okay, it will lead into social isolation and therefore significantly boost the psychological well-being. The social connection असेल, social support असेल. Okay, then it will help to boost म्हणजे whatever their well-being is there, whether it is mind well-being, mental well-being or physical, it will boost, and therefore psychologically they're able to come out of whatever the tragedy they had been to. Here the tragedy is they're not able to verbalize, they're not able to show their emotion, they're not able to do their day-to-day activities, they're not able to walk, talk, stand, nothing. You understood? So it's a big deal for the person who is affected by stroke. Social connection. If you have seen that मुन्ना भाई MBBS, उसके अंदर दिखाए हैं कैसे elders साथ में बैठते हैं, कैरम बोर्ड खेलते हैं, पत्ते, you know, they play some chess or some cards, पत्ता बोलते हैं उसको. Why, what are those activities are not important. The important thing is they come together. That's very important. So whatever be the aspect, whether it is stroke or whether it is diabetes, whether it is hypertension, whether it is cancer, whatever be it, if you have your social connection, if the social support, even the family support, number one has to be family support. You understood? And spiritual support. Matlab, I need to support myself, my willpower has to be strong. Then only everything will be strong around me. If you agree with this, then yes, we can very well go about taking care of the stroke rehabilitation. I hope either you have understood or not, depending upon if you have any questions. So thank you very much.
पे ठंड लग
Thank you, ma'am, for that highly informative session. Your insights have reformed a crucial message for all healthcare professionals. Recognize the science, respond in time, save the brain. Let us express our appreciation with a warm round of applause.
Moving ahead, we welcome to another essential phase in stroke journey, rehabilitation and recovery. Recovery may not happen overnight. Sometimes it begins with a word spoken again, a hand that begins to move, or a first independent step. Rebuild strength, restore independence, rediscover life. Our third session, Stroke Rehabilitation and Recovery, will be conducted by Ms. Flavia Disa, Assistant Professor at Riddhivinayak College of Nursing. Madam has completed her Masters in Medical Surgical Nursing from Bombay Hospital College of Nursing and has 10 years of combined teaching and clinical experience. Her expertise and experience will certainly help us to gain a better understanding about stroke rehabilitation and recovery. I kindly request Ms. Flavia Disa to come forward and conduct the session.
Good morning to one and all present here. So we'll move on to the next session, and that's stroke rehabilitation and recovery. Okay, so stroke rehabilitation recovery. Now, the earlier sessions, you all know what is stroke, okay, and you have knowledge regarding this. Now, we'll see what is the rehabilitation and recovery aspects. So the learning objectives in this session, you'll learn regarding the importance of rehabilitation and recovery. Next, the phases or the stages of stroke recovery. You'll identify the goals of stroke rehabilitation. Fourth is discuss the multidisciplinary approach in stroke rehabilitation. The fifth one, explain the roles and responsibilities of nurses in stroke rehabilitation. And lastly, the strategies to prevent complications and promote functional independence. Okay, so what is stroke rehabilitation? Stroke rehabilitation is a planned, goal-oriented process of care that helps people recover lost abilities, improve function, and achieve the highest possible level of independence and quality of life after a stroke. So this basically, the word rehabilitation tells us that after a stroke, the patient is affected totally physically as well as the cognitive skills also diminishing. So the patient needs to recover, the phase of recovery, the phase of recovering the lost abilities, improving the function together and providing a level of independence. So together makes a stroke rehabilitation. Okay, so the importance here is restoring function. Restoring function means what? The patient earlier he was able to do all the activities, but now after a stroke he is not able to do it. So the first aspect is restoring function. So whatever lost movement, physically he is totally, the abilities to stand, to hold a glass, everything is lost. Slowly to recover that, then the strength, the speech, the cognitive levels, everything. So all this function needs to restore. Next is prevent complications. So after a stroke, the patient, is bedridden. If you don't take proper care of them, then the development of bed sore, contracture, pneumonia, blood clots, they start. Okay, so preventing such complications, whenever the patient is a stroke patient, you need to understand that giving total hygienic care, like every 2 hourly you need to change the position, so to prevent the bed sore, physical activity, physiotherapy, all this should be involved so that we can prevent further complications. Third one is promote independence. So promoting independence is also very, very important, because stroke is not for a short period of time, it's a journey. Sometimes it may take months, sometimes it may take years to recover to become the near normal phase. So that is why just making the patient do activities of daily living so that he'll be able to be independent, at least to do his own activities, enables the patient to perform daily activities and become self-reliant. So that is very important. So you may not be a burden to someone. And last is improving the quality, enhancing emotionally, then patient should be able to attain his confidence, social values, overall development is very, very important to improve the quality of life, so that you may not be dependent on your family members for a long time. At least you can do your things on your own. Next is goal. The overall goal of stroke rehabilitation is to help individual to achieve the highest level of function, independence and participation in family and society. So the first is, as we know, it's restoring function. Second, prevent complication. Third is promoting independence, improving the quality of life, and lastly supporting and returning back to its near normal phase in the home as well as in the community. Okay. How stroke affects the body. Now these are the aspects where stroke affects our body. First is brain and thinking. The memory, attention, judgment, everything is affected. Problem solving may also change. Next is movement and strength. There will be weakness, there will be paralysis. It can affect one side of the body, okay? And walking, even walking few steps can be difficult. Next is speech and communication. Aphasia or slurred speech can affect speaking, understanding, reading, writing. These are the basic things which get affected. Vision and sensation. Blurred vision or double vision can be there. There will be visual field loss in some cases. Numbness or altered sensation may also occur. Next, the swallowing. There's difficulty in swallowing, dysphagia. Patient will find difficulty in swallowing. It might get affected here. And then lastly, balance and coordination. Dizziness, poor coordination. There'll be reduced balance. Patient will not be able to stand alone on his own feet. Common problems after a stroke attack. First is weakness or paralysis. Next is the speech and language will be affected. Swallowing difficulty. Balance and coordination. Next, memory, thinking. Fatigue will be there in such patient. Patient will be physically as well as mentally tired. Vision and sensation. And lastly, mood and emotions. Now there are various phases in the rehabilitation and recovery. First is acute phase, which lasts for 0 to 7 days. So in this, there will be medical stabilization and monitoring. The word acute, what it says, it will be of short period. Medical stabilization, monitoring of the overall vitals, preventing the complication, early mobilization and positioning, patient and family education. So this phase lasts for only 0 to 7 days. This is the acute phase where the patient is admitted and all the procedures take place here. Next is subacute phase, which lasts for 1 week to 3 months. In this, there's intensive rehabilitation, physiotherapy, occupational therapy, speech therapy will be there. Improve the strength, balance and mobility, regain daily living skills, speech, swallowing and cognitive training will be there. So this is a subacute phase which is for 1 week to 3 months, where the patient will be slowly moving on to the therapy part, speech therapy, occupational therapy and physiotherapy. And lastly, that is chronic or community phase, which is 3 months and beyond. It can take months to years or just few months depending on the patient. So continue exercise and practice. So here the patient will be at the home care, will be discharged and he will be at home. Return to work or hobbies or social life, managing risk factors, ongoing support from the family and community. So he'll be discharged, he'll be at home, and the therapy will be ongoing till the patient is at the near normal state. Okay, so stroke rehabilitation is not the effort of one person, it is a multidisciplinary approach where the entire team is involved. Not one person can cure the patient. So here patient and the family at the center, and there are various people or there are various faculty which gets involved. First is physician, which takes the overall care. Second, the nurse provides 24/7 care, provides support, monitors progress, educates, supports the patient and the family. Then comes the social worker, assists with the discharge, planning, resources and reintegration into the community. The social worker means the person, if you have any financial issues, you have financial crisis, because stroke is not just something which gets cured within a month or so. So you are totally dependent, you are under very financial crisis over here. All your loss of finances will be there. You need financial support. For that, social worker gets involved, and then he will provide you with such government schemes which will help you in overcoming your financial crisis. Next is the dietitian, provides nutrition, guidance, support, healing and preventing further complications. So dietitian here recommends what food can be eaten because you have a swallowing difficulty. In that case, it will provide a diet chart. Psychologists are here to help you overcome all your emotions, you are going through such a lot, like there's a stroke is such a big emergency and going through a lot. You want to speak, you want to express your emotion, but you can't do that because there is some parts of your brain which are affected. So in such cases, psychological environment also is very important. Speech and language therapist, because you have a slurred speech, you're not able to talk properly, so speech and language therapists are involved. Next is occupational therapist, enhances ability in daily activities and promotes independence. So occupational therapists help you to how to engage or how to come back to your own occupation, like how to hold a glass, how to hold a side rail or side bars, how to walk, how to engage in a simpler occupations which you can do it on your own. Physiotherapist involves or improves the strength, mobility, balance and coordination, which is very, very important. Active as well as a passive physiotherapy. So this is a multidisciplinary approach where the entire healthcare is involved. Okay, now the first thing is physiotherapy. How it will help? It will strength. It will give us the strength. The muscles totally become weak. There's spasticity of muscles. So muscle training will be there. Next is enhances balance and coordination. So balance and coordination is affected because patient is having paralysis. So in such issues, the balance and coordination should be met that physiotherapist will help. Next is improves mobility, facilitates walking, transfers, enabling better mobility. So mobility is also very important. Next is increases flexibility because there's stiffness, spasticity of muscles. The range of motion is affected. So next is increases flexibility. Next promotes functional independence, help perform daily activities like dressing, bathing, eating. So these are all performs daily activities. So at least the physiotherapist helps the person to meet this basic needs. So at least he can dress himself, he can have bath himself, he can eat on his own. So that functional independence will be gained. And lastly, enhances quality of life. It boosts confidence, it lowers the dependency on others and helps in emotional well-being. So once you gain good balance, good coordination, good mobility, then it will give you confidence. It will increase your confidence and further it will give you a positive mindset to recover early. Next is occupational therapy. Helps stroke survivors rebuild the skills needed for daily living, promote independence and improves the quality of life at home, work and in the community. So improves daily skills like self-care, dressing, grooming, how to hold a comb, how to hold a glass of water, how to comb your hair, how to eat, how to go to the washrooms. Enhances upper body function, strength, coordination, fine motor and gross motor skills. Next is promote independence at home and work. Facilitates return to household task, work, hobbies and meaningful roles. So household task, how to hold certain objects, how to go to the washroom alone. The occupational therapist also can inculcate new hobbies. So at home, if you're at home, if you're not having a job or something, at least at home you can practice some hobby. So it will divert your mind. Then adapts environment and task, recommends home or work modification and assistive devices to increase safety and independence. Recommends home or work modification. So at home or work modification, if such patients are there at work, there should be some facilities for them, like a ramp should be there, or in the washroom there should be sidebars. For walking there should be sidebars. So such assistive devices will help the person, to walk at least, to balance. Next is support cognitive and visual perceptual skills. Helps improve the memory, problem solving, attention, perception and visual processing. So this occupational therapy also will support cognitive, visual, perceptual skills. The occupational therapist, tell you to do certain activities which will help you to increase your cognitive levels. That they will give you simple math sums to solve. They will give you some colorful objects wherein you need to place it. They will play some games with you, so that all these skills will help in improving the cognitive level as well as solving certain problems. And with the colorful objects, they will give you some game to do, so that your visual perception will increase. Next and lastly, it enhances participation and quality of life. So encourages, this all activities will help you to engage in something, to go out socially, be active. There will be a diversion of mind. It will be a recreation for your mind, and you will become more and more creative, because all these activities will help your brain to start, working, start understanding things. Now there's stroke recovery. Stroke can affect the ability to speak, understand, express the thoughts, swallow, safely. Speech language pathologists help individual regain this essential skills and confidence. So first is speech rehabilitation, language rehabilitation, swallowing rehabilitation. So here the speech rehabilitation, from slurred speech, at least the patient should be coming to a near normal stage where, the person, the family member should understand what the patient wants to tell. So speech rehabilitation, slowly by slowly, the speech therapist will start training you in such a manner that further you'll be able to come to a near normal phase. Language rehabilitation helps improve understanding the language, enhances ability to express thoughts, works on reading, writing and comprehension. So this language rehabilitation specially works on the reading part, writing and comprehension. Swallowing rehabilitation assesses swallowing difficulties like dysphagia, then safe swallowing techniques helps prevent choking and aspiration and ensures poor nutrition and proper nutrition and hydration. So swallowing rehabilitation, what they will do is they provide a safe swallowing techniques. They will help prevent aspiration because the chances of aspiration and choking is there in such patient, and they will provide a good diet chart to improve the nutrition level. Key roles and responsibilities here. Okay, so the nursing care, nurses play a very important role in the stroke rehabilitation. With their clinical expertise, empathy and patient education, nurses empower survivors to regain independence and improve quality of life. So what is the role of a nurse in such a rehabilitation phase? First is assessing and planning the care. You need to assess. The first step always in nursing is assessing. So assessment as well as planning the care of the patient. You need to assess the patient and then you need accordingly to plan the care. Next is provide direct care, like assess the patient in daily activities, ADL, maintain safety and prevent complication, encourage participation in therapy sessions. Third is patient and family education. So the nurse also has a role in the patient and family education. So she is always in contact with the family members. So need to teach the family members like how to handle such situation, how the patient can improve his activities of daily living, educate on medication, diet, exercise, risk factor control, and also educate them to provide a emotional support and always be positive. There should not be any negativity. So the patient, if there's a positive environment, the patient's recovery will be faster. Next is coordinate with the team. So collaboration with the doctors, the therapists, physiotherapists, occupational therapists, speech therapists, dietitians, and social workers. So team collaboration should be there. The team meetup should be there. There should be proper coordination like regarding the recovery of the patient. Next is monitor and evaluate. Monitor the progress and document the improvement. Modify the care plan as needed. So you need to continuously monitor the patient for any further complications or any bed sore or any improvement which is getting hampered, or there is some problem with the patient or the family. So the monitoring is very important. And lastly is providing empathy to the patient. So you always need to be empathetic towards the patient, and due to that you will help the patient to improve. There will be a positive attitude, always boost confidence in the patient, always encourage and provide a positive environment so that the recovery will be fast. So these are some prevention, common complication and prevention strategies. First is muscle weakness and contractures will be there. So to prevent that, early physiotherapy is very, very important. You need to start the therapy as soon as possible so that you can prevent contractures and muscle weakness. Next is DVT, that is deep vein thrombosis. So for them, use the compression stockings, that is very, very important. Leg exercises, again the physiotherapy is involved, and early mobilization is important to prevent DVT. Next is pressure injuries, bed sore. So bed sore is also common when the patients are totally bedridden. So immediate physiotherapy is recommended to further so that the bed sore will be avoided. Then is pneumonia. Prolonged bedridden condition can give rise to pneumonia. Encourage deep breathing exercises, upright position while feeding, oral care, swallowing assessment, proper hygiene, the total sponge bath, back care, hand and feet care, everything, all the hygienic measures should be followed so that you can avoid pneumonia. If the patient is hygienic, there will be less chances of the patient getting any infection. Swallowing difficulties, dysphagia, in such condition, the speech therapist as well as the dietitian is involved, wherein you need to put a very good diet chart. You need to give the patient a diet chart, so the diet chart should be followed, and slowly help the patient to encourage the patient and the family members at the same time to solve the swallowing difficulties. Urinary tract infections. So when the patient is having catheter, the patient might have chances of getting UTI. So for that, perineal hygiene, timely toileting, avoid unnecessary catheterization. These all measures should be followed. Next is constipation, high fiber diet, adequate fluids, regular toilet routine, early mobilization. So these can help in avoiding constipation. Pain, shoulder pain or post-stroke pain is very common. So here, pain assessment, gentle exercises, proper positioning and support, and lastly, medications are prescribed. Comfort devices can also help. Next is falls. So fall is a condition wherein the patient has problem with the balance coordination, so patient can have falls. So in such cases, fall risk assessment should be done regularly. Safe environment should be given, assistive devices should be given, the bedside rail should be put up always, and there should be someone with the patient always, because such patients have a risk of falls. So a family member should be there. Lastly, emotional challenges. Now such patient, a stroke is a big journey. It's like it might take months to years. So it's not something which gets cured off easily. So it's a journey. So there will be some emotional changes. People will get frustrated. The patient itself will be frustrated. The family will be under financial crisis. They will have a burden, like the normal routine will be disturbed because of one family member, because the family member is admitted or family member is at home and dependent totally. So everything will be disturbed. So there will be some emotional changes in the family, in the patient as well. So to avoid this, there should be counseling sessions, there should be psychologists involved, so that the emotional development should be there. There should be a positive environment always. Okay, activities of daily living. They are everyday tasks that people need to do to take care of themselves. After a stroke, relearning these activities is key to regaining independence and self-confidence. So activities of daily living, everyone is aware. So here, bathing, dressing, eating, toileting, transfers from bed to chair, or from chair to again bed, mobility and basic home care. These are all the activities of daily living. So once there are other adaptive devices, like there's a shower chair, there are grab bars, there is a special spoon which is given to such patient. Then there are walkers. These are the assistive devices which will always help the patient to move on independently. So we'll see what are the cognitive aspects here, what happens emotionally after the stroke. There will be depression, anxiety, social isolation, family support, counseling. So depression means there will be sadness, hopelessness. After a stroke, the patient himself will be totally shattered. Then anxiety will be there. The patient will think that will I get cured or not? There will be constant worry, restlessness. It might affect the sleep, concentration, and daily activities. Relaxation therapy and support can reduce the anxiety. Next is social isolation. Once you're in your bedridden condition or once you're dependent on someone, you become socially inactive or socially isolated because you are at home all the time. You cannot go out without someone. You're totally in a near normal condition and not a normal condition. So that social isolation automatically comes inside you. You know, you cannot go out with your friends, you cannot go out and meet up with your friends. So this all things will give rise to social isolation. Family support, emotional support from the family builds confidence, involves the family in care, decision and rehabilitation process, help in coping with challenges and daily routine. So family support is very, very important. The family itself has a negative outlook towards the patient, and the patient will never improve his condition. His condition will go on deteriorating day by day. So family should be very supportive, have a positive attitude so that the patient improvement and recovery will be faster. And last is counseling. Counseling is also very, very important because for your mind always affects the body and the body affects the mind. There's a interrelationship. So counseling session should be there. Why? Because the patient will be positive all the time. Patient will get motivation. Patient will improve his confidence. And that is why counseling is important. Next is stroke recovery is a journey. It is not a race. It's a journey. Families and caregivers play a vital role in helping survivors regain independence, confidence, and quality of life. So here you can see there's emotional support, assisting in daily activities, the role of family here, support rehabilitation, manage medication, promote a safe environment because patient can tend to fall. In such cases, promoting a safe environment is important. And be always patient with your, there should be a lot of patience because it is a journey. It is not something which the patient will recover faster in a month. So it's a big journey. So family support, family plays a very, very important role in stroke recovery. Next is, here is home-based rehabilitation helps stroke survivors improve strength, confidence, and quality of life in the comfort support of their home. So at the home basis, what you can do is provide a safety environment. Next is exercise program. Follow a prescribed exercise routine. There should be range of motion, strength, balance, walking practice. So these all activities should be there in your exercise program. Next is nutrition, balanced meal containing fruits, vegetables, low salt, low sugar, low fat diet. Drink plenty of water, maintain a healthy weight. Medications, do not skip any doses, use a pill or organizer, a reminder, keep medicines out of the children's reach. Next is following up with the doctor, the physician, okay, the entire team, the occupational therapist, physiotherapist. Then monitor the BP, sugar, other health conditions, report any new symptoms immediately and update the therapy plan as advised. And lastly, the lifestyle. Your lifestyle, yes, as everyone knows, quit smoking. You should not have any type of habits that will ruin your health. Manage stress, get adequate hydration, stay socially active and stay positive. That is very important. Role of nurse in stroke rehabilitation recovery. As we had already seen in the earlier slide, there should be assessment and monitoring, then mobility assistance, skin care, pressure injury prevention should be there, nutrition, hydration, swallowing safety, medication management, education and motivation to the patient as well as the family, and caregiver training. So a caregiver should always be there with the patient, and you need to give them proper training for it. So these are the role of the nurse. Next is a stroke recovery timeline. Okay, so the journey from the hospital to community is not that easy, for the patient is admitted in the hospital for their acute care. Next phase is early rehabilitation. Next, home, the patient gets transferred to home, and then also there's ongoing rehabilitation to the patient where the physiotherapist, the dietitian, occupational therapist come at home and give you the therapy. And lastly, the community. Once the patient comes to a near normal phase, then he can move to the community. So I've come at the end of the slide here. So key takeaway points after stroke rehabilitation and recovery. First is keep moving. Always your daily life should have some exercise regimen to keep yourself moving. Your sedentary jobs where you come just sit and the PC is involved, there's no exercise, and because of that further problems take place. So keep moving all the time. Next is eat right. You should have a well balanced meal containing of all fruits, nutrients, everything. Next is take medication as prescribed, never skip the doses. Next, attend follow-ups. Whatever follow-up is there, the patient should visit the doctor or the therapist. Next is care for your mind and emotions. Yes, you should practice yoga, meditation. You need to have your mental hygiene to have your to improve your physical condition. Always the mind affects the body and the body affects mind. Always remember this is the relationship. Next, stay connected with your family, friends, and in this process you should stay connected with your family process, because it always man is a social animal, and you need to meet your friends, your families to get connected, and it helps in diverting your mind. And lastly, adopt a healthy lifestyle. So I hope everything is clear over here in stroke rehabilitation and recovery. Thank you, everyone.
Thank you, ma'am, for such a practical and encouraging session. The session was beautifully highlighted that rehabilitation is not merely about recovering function. It is about enabling the individual to regain independence, confidence, and quality of life. Let's appreciate ma'am with a round of applause.
As nurses, our responsibility does not end with identifying the immediate problem. Continuous assessment enables us to anticipate risks and prevent avoidable complications. And therefore, assess early, anticipate risks, prevent complications, protect recovery. Our fourth session is comprehensive stroke assessment and prevention of complications. The session will be conducted by Ms. Nupur Shivtare, clinical instructor at Riddhi Vinayak College of Nursing. It is my pleasure to introduce our resource person. Ms. Nupur Vinay Shivtare ma'am upholds a master degree in medical surgical nursing. Ma'am brings a rich combination of clinical, academic and infection control experience. She worked as an oncology nurse at Kokila Ben Dhirubhai Ambani Hospital from 2019 to 2021 and later served as coordinator for the COVID-19 vaccination drive at Tata Consultancy Services, Hinjwadi, Pune in 2021. In 2023, she worked as nurse in charge at Radiant Hospital, followed by her role as a NAPH infection control nurse at Riddhivinayak Multi-Speciality Hospital from 2023 to 2026. Gaining expertise in infection prevention, patient safety, and clinical practice, we are delighted to have her with us today. Ma'am, we now invite you to take over the session.
I don't know if it is working because that is not connected. No, no, yeah, there is a problem.
Okay, hello everyone. So this is Nupur Shivtare presenting the topic before you. So before I'll start with my presentation topic, I would like to find something under your chair. Can you find for me? Yes? Under the chair? Yeah, it's a small brain warming session for you. Okay, so can you see the screen? What I have found here? Okay, so what we are going to do is you give me your 30 to 40 minutes and then we are going to learn how is the comprehensive assessment of the brain. Okay, are you ready with me? Yes? Okay, thank you. So, I'm going to take only 30 to 40 minutes and we are perfectly going to learn what is comprehensive assessment, okay? And the prevention of the complications. Fine. So, everyone is with me? Yes? Okay. So, there are 7 keywords we are going to focus on and my whole slides are depend on that words only. Okay. Now, first is we are going to stabilize the patient. Okay. Can you repeat after me? Stabilize the patient. Next, we are going to what? Recognize. Okay. After recognition, we are going to what? We are going to quantify. Quantify means what? We are going to measure. Okay. Next is image. Next, again, we are going to investigate. repeat, and prevent. So these are the 7 words we are going to focus on. Are you with me? Yes? Let's unreveal the one aspects. Okay. So again, recognize, stabilize, quantify, image, investigate, and repeat. So in recognize, we are going to do the BFAST assessment, last known well. Next in stabilize, we are going to see the ABCD plus glucose and the vitals. Quantify means we are going to measure the actual signs and symptoms through GCS, NIHS focused neuro examination, image. Now in image, we are going to see the CT scan, the CTA, MRI as indicated, investigate labs, ECG and the cause. Okay, and the repeat, we are going to prevent the second episode of the stroke. Okay. So again, this is the stroke pathway, that is recognition, assessment, imaging, treatment, monitoring, complication, prevention. Okay, till now you are okay. I think 50% things are covered here through these slides. Okay, now first section we are going to see is that what is happening, what is to be recognized, and why time matters. Okay, that is the basic important thing. Now we have gone through all these things. Okay, so just I'll repeat it, just a gist of this. So ischemic stroke, hemorrhagic stroke, neurological deficits, and stroke is a real time critical emergency. So ischemic stroke, but obviously it is a result of arterial occlusion. Hemorrhagic is rupture of the vessels, and neurological deficits will resemble the impairments, sensory impairments. Okay, next. Now the types of this stroke again, ischemic, intracerebral hemorrhage, subarachnoid hemorrhage, and transient ischemic attack. Okay. Now what is the major risk factor? Okay, first of all, we are going to give the most of the focus on the hypertension. Now we are categorized into 2 different modalities, that is the modifiable and non-modifiable. So modifiable is, okay, you can change. So hypertension, we can control the BP, diabetes, we can control the glucose levels, okay, dyslipidemia, smoking, obesity, physical inactivity, unhealthy diet, excess alcohol, arterial fibrillation and cardiovascular disease, medication and non-adherence. And non-modifiable, which cannot be changed, like the increasing age, okay, the previous stroke episode, family history, genetic factors and prior vascular diseases. Okay. Now next is, we are going to see the pathophysiology. There is a core and numera, okay. You have to identify the core and the numera basically. So the core is injured tissue, okay, where the ischemia exactly occurs. So ischemia is nothing but lack of blood and the oxygen supply to the tissues. Numera, okay, it is a hypoperfused but potentially savageable tissue around the core. So as the image is showing you that the numera is the outer part and the ischemic core is the pointed red circle, okay. Next, we are going to recognize the stroke, that is again BFAST. So from morning we have been learning about BFAST, right? So again quickly I'll revise it. So B stands for balance, E stands for the eyes, F stands for the face, A stands for the arm, and S stands for the speech. And T stands for the last known well symptom or the time. So again, sudden loss or the balance for B, then E is the eyes, sudden visual loss or double vision, F is face, A means arm, and S means speech, okay. So slurring, aphasia and inability to speak, okay. In arms, you can see a arm drift or a pronator drift. In face, again the facial drooping and the asymmetry and the time, okay. So last known well means we are going to learn what is last known well. So first of all, we are going to see that our brain, okay, the time is brain. So we have to emergency, it is an emergency condition, so we have to do a emergency treatment for this patient. So your time has value, okay? So according to the nursing point of view, our priority is record the exact time when was the patient known well, okay? Then activate the stroke response pathway. So what was the stroke response pathway? We have learned that is first recognize, stabilize, right? Then again investigate. So all these things come under the stroke pathway. Do not delay the emergency imaging. Next is check the bedside glucose levels, document the baseline data, that is neurological functioning as well as the vitals of the patient, and communicate clearly using a structured handover, that is S-bar, okay? S-bar everyone knows? Yes? Okay, good. So here there is a time period of 60 minutes. So your first 10 minutes, it's a door to the evaluation. In evaluation, we are going to do the assessment, okay? We are going to recognize the last known well time. Door to the stroke team means you have to generate a stroke code, activate the stroke code, and okay, get the treatment done. Next is door to the CT and the MRI initiation. That is to be done, okay, between the span of first 30 minutes. Next is door to the drug intervention, so to start the therapy, okay. Next is door to the stroke unit admission. So all this covers how many minutes? 60 minutes. So 1 hour is very vital for you, okay, to manage the patient. So we are going to see what is last known well. So this last known well is patient who was seen last well. For example, this is 1820, means at 6:20 the patient was well, he was talking nicely with you, okay. Now the patient has shown the symptom at 6:35. So your last known well time was what? 6:20. This is the last known well time. That is very important, okay, when you write down the history of the patient, especially with the stroke. And the patient arrives at the emergency department is at 6:55, okay. So time is brain, every minute matters. Document the exact last known well time, okay. Yes. So what are you going to do? You are going to document last known well time. Now how to recognize the last known well time in stroke? The last known well, the last time the patient was definitely known to be at the normal neurological baseline. The patient is nicely sitting, walking, standing, laughing, okay. So this is the neurological baseline, normal neurological baseline. It is not necessary that the time when the symptoms were first noticed. Okay, now you have to ask certain questions. When was the patient last seen completely normal? What was the exact time? Who saw the normal at the time? What were they doing? Where they were communicating normally? If they woke up with the symptom, ask when was the patient last normal to be going before the sleep. So these are certain questions you have to ask before identifying the last, okay, known well time. So here there is a breakdown of the stroke treatment clock. Okay, so 0 to 4.5 hours are very essential to stabilize the patient. You can initiate the thrombolysis treatment. Next is up to 6 hours, okay, selected LVO, that is large vessel occlusion, maybe in the cerebral, okay, carotid artery or major arteries where you find any occlusion or obstruction, so you can mechanically repair them. Next is 6 to 24 hours, selected patients with appropriate imaging and thrombectomy. Then beyond acute reperfusion windows, okay, what is reperfusion? The area in the brain where the oxygen and blood supply is less, we are going to revert it, okay, we are going to provide the oxygen and the blood supply, so that is called as reperfusion window. So again, stroke unit care, you have to shift the patient in that unit, and we have to prevent the complications. And recovery can continue for months or days. So every minute matters, but 4.5 hours is not the end, okay? If it is even beyond 4.5 hours, okay, we have evidence-based practices, okay? Now we can recover the stroke patients. So it is not the end of the stroke care. So what about a patient who wakes up with the stroke? Okay, a person who goes to the sleep and wake up with all the paralyzed symptoms. So how will you know the last known well time? Yes, the patient, okay, before going to sleep, what was the time? You have to exactly note that time. So this is the one of the most interesting reasons of the last known well time matters. So imagine 10 p.m. patient goes to the sleep normal, 6 a.m. the patient wakes up with the weakness, and we don't know the exactly when the stroke occurred. So this is called as a wake up stroke. Got it? Okay. Now section 2, we are heading towards the history, the ABCD and the focus neurological examination. So history of present illness. So there are 10 different questions. Okay, I've minimized the questions. So these 10 questions are very important to ask. So what happened? Sudden or it was a gradual onset. What is the last known well time? We have learned, yes. Now what symptoms started and in what sequence? Is there weakness, numbness, speech difficulty, vision change, imbalance, or any headaches? Now, has the patient had a seizure or loss of consciousness or trauma? Is the first episode or has it happened before? What was the patient's baseline function before the event? What medicines were taken today, especially anticoagulants, antiplatelets? Any recent surgery, bleeding, infection or invasive procedures? And what are the known vascular risk factors and allergies? So these are symbolically 10 golden questions you have to ask when you are taking the history from the relatives of the stroke patient. Now we have to do a primary survey. So this survey is ABCD, okay? So first the airway, that is patent, okay? Gag, cough, when appropriate secretions are there or aspiration risk are there, we have to find it out. Next is breathing, so respiratory rate, then oxygen saturations, okay? The lung sounds, abnormal lung sounds, oxygen only as clinically indicated. Next is circulation, we have to, again, the risk factor was hypertension, right? So you have to check, continuously monitor the blood pressure of the patient, the pulse, the ECG rhythm, IV access and perfusion. Disability, that is loss of consciousness, and the GCS scale, pupils, okay, dilated or contracted on the reaction of light, glucose, focus, neurological examination. And in exposure, temperature of the skin, then next is trauma, pressure injury risk. So this is the primary survey, A, B, C, D and E. Now vital signs, yes, everyone knows about the vital signs. So blood pressure, record accurately, repeatedly and avoid certain unprescribed changes, okay. Next is temperature. So fever can worsen the neurological status of the patient. So every time monitor the temperature every 2 hourly. Next, pulse rhythm, look for the irregular rhythm. Glucose, check the signs of hypoglycemia. Now what happens? The stroke patients can resemble the certain times resemble the signs of hypoglycemia also. So glucose test again is against golden standard test to diagnose the hypoglycemia and the stroke, okay? You can differentiate immediately. Next is the oxygen saturation and the respiration. Okay, now the level of consciousness and the mental status. Observe the alertness. Is your patient awake? Is your patient drowsy? Unresponsive, you have to check it. Next, assess the orientation. Time, place and person. Assess the attention and the ability to follow one-step and two-step commands. Look for certain agitation, confusion, reduced responsiveness. You have to talk, okay? Verbal communication should be there to know the alertness of the patient and the responsiveness. And a declining level of the consciousness is a red flag, okay? So here you can see the alteration in the level of consciousness and the GCS scale. Now we are coming towards the GCS scale. Okay, everyone knows about this. That is eye-opening, verbal response, motor response. Okay, so the total is 3 to 15. Okay, now always document the component, not only the total. Example, E3, V4, M6 equals to 13. Now here again, E is what? Eye-opening, that is E is 3, that is 2 voice. So the patient is responding to the voice. V4 means the verbal response is confused. And M6 is he obeys your command. So the total score is 13. This is NIH stroke scale. Okay, madam has discussed with you the NIH stroke scale. So there are different domains in that, that is awareness, consciousness, coordination, language and speech, movement and the senses. So 0 to 5 is minor stroke, 6 to 15 is moderate stroke, 16 to 20 is moderate to severe stroke, and 21 to 42 is severe stroke. Okay, now next is the pupillary assessment and the eye findings. Okay, now the major part you can also rule out through the eyes. Okay, the patient can show typical signs that we are going to learn. First is assess the pupil size, equality and reaction to the light. Okay, next is observe the gaze position. Now we are going to learn in further slide what are the 6 cardinal signs of the gaze and extraocular movements. Assess visual fields when the patient can cooperate. Look for the gaze deviation. Gaze deviation means vision. Okay, when you are looking at a person, okay, when you are straight looking at this side, okay, your eyes might turn at the another side. Okay, so look for the gaze deviation, diplopia or new visual field loss, new anisorkia. Then next is fixed pupil or sudden worsening consciousness requires urgent escalation. Okay, now the next slide is H. Now what we are going to learn through this? Okay, can you move your eyes? Okay, can you roll your eyes like this? From top to bottom, left to right, again top to bottom. What it is the, okay, you are going to assess certain cranial nerves. So this is the assessment. So first, upright is cranial number 3. Next, okay, is 2, again to your right is cranial number 6. Cranial number is, nerve number is 4, then down right. Next, again towards to your left is upper side, that is cranial nerve number 3. Again it is 6 and again it is 4. So these are the 6 cardinal directions for the eye movement. Okay, any changes in this can, okay, you can identify which cranial nerve or which, okay, or you can like simply identify the signs of the stroke. Now the cranial nerve and the bulbar assessment. So cranial nerve number 2, that is visual acuity, fills as appropriate. Okay, 3, 4 and 6 pupil response and eye movements. 5 is facial sensation and jaw functions. Okay, the 7 is facial symmetry, eyebrows, raise eyebrows, close eyes and smile. So like that you can assess it. Voice quality, cough, palate movement and swallowing safety. Okay, that will be 9 and 10 number. Next is, okay, we are going to see for the tongue movement and the articulation, that is 11 and do not 12, and do not provoke a gag reflex routinely. Use strange swallowing screening procedures. So this is the cranial nerve assessment. Now in motor assessment, inspect for the spontaneous movements, Next is arm drift. Okay, in the starting, madam has beautifully showed, a student has beautifully showed the arm drift. Okay, next is test the muscle power, compare the right and the left sides, assess hypotonia, normal tone, assess the coordination, finger to nose, heel to shin when appropriate, record functional ability. Okay, now next we are going to see the MRC scale. So grade 0 is complete paralysis. Grade 1 is flicker of contraction. Grade 2, that power detectable only when gravity is excluded by postural adjustment. Next is grade number 3, the limb can be held against the gravity but not resistance. And grade number 4, limb can be held against the gravity and some resistance. And 5 is normal power. So this is the muscle strength, okay, grading power. Now the arm drift. Okay, so ask the patient to close the eyes, hold on for 10 seconds, ask him or her to keep his or her hands forward, so the arms get drift. Okay, it is displaced from its original place, so that is the arm drift. Now coming towards the sensory, language and the neglect assessment. So sensory, language, neglect and the key distinctions we are going to learn here. So the light touch, pain, then next is temperature. So you are going to assess in the sensory part. In language, you are going to ask the patient to name the object, repeat the phrases, follow the commands, describe a picture, differentiate aphasia and dysarthria. Okay. So here in neglect and extinction, you are going to observe the response, simultaneous bilateral stimulation and attention to one side of the body space. Okay. Now here, for example, a patient who knows the answer but cannot name an object, okay, may have aphasia. Next is a patient who knows the words but has slurred speech or articulation may have dysarthria, and do not assume inability to speak means he is not able to understand. Okay. Now swallowing and aspiration risk. So keep the patient kneel by mouth, assess for the again alertness, facial and the oral motor functions. Okay, what are the red flags? Coughing, choking, wet or gurgly voice, drooling, repeated throat clearing, okay, pocketing food and prolonged chewing. So these are the red flags. So you have to immediately stop the oral foods. Position upright for the assessment and feeding when permitted. Use prescribed texture liquid modifications and involve speech language therapy when indicated. Monitor for aspiration pneumonia. So these are the key points when you are doing the swallowing and the aspiration assessment. Now communication, if the patient is not able to communicate, give them the yes or no cards. Okay, ask them for certain questions so it is okay clear that what the patient wants to have or wants to say. So assess the orientation, attention, memory. Okay, identify the aphasia, dysarthria, apraxia and impaired comprehension. Use short sentences. Allow extra time for the response of the patient. Use communication boards and assess the mood, anxiety and behavior of the patient. Now again in functional and baseline assessment, okay, we have done the ABCD assessment, right? So same applies here again. So you have to give ADLs. ADLs is nothing but you have to give the assistance for the daily livings, okay? Then next is cognition, speech, incontinence and living situation. You have to see the incontinence is again a major problem. So you have to again give keep the proper hygiene of the patient. Then current function, that is bed mobility, sitting, transfers, ambulations. So if you don't do this, the patient is again in the risk of having bed sores. The next is upper limb function and hand dominance, assess for the fall risk and need for the assistance, identify caregiver ability and the home barriers early, document the changes from the baseline. Now investigation. Now this is really a like important part, investigation. So what you are going to investigate. So first is the golden rule, you have to do non-contrast CT, not the contrast CT. First golden rule is do the non-contrast CT. Why? Because it is very easy to differentiate the hemorrhagic stroke or the ischemic stroke by the help of the non-contrast CT. So it rapidly identifies the intracranial hemorrhage and the other major abnormalities. In acute ischemic stroke, early CT may be normal or show subtle early ischemic changes. So always go for non-contrast CT first. Next is MRI brain. So diffuse weight MRI. Next is highly sensitive for the acute ischemia. Okay, now next is vascular imaging, that is CTA, MRA. Okay, so you are going to do this to identify the LVO, that is large vessel occlusion. Okay, so again simplifying for you, non-contrast CT, first line imaging, quickly and widely available to differentiate between hemorrhagic and the ischemic stroke. Next we are going to see the additional imaging, that is again CT angiography. So it evaluates intracranial and extracranial blood vessels. And next is MRI brain or DWI, that is diffusion weighted imaging. Okay, so again for you to understand, these are the two different images. Hemorrhagic, okay, you can see the black dot and a white dot, so that indicates the hemorrhagic, okay, non-contrast. And in ischemia, it shows only a gray circle, so that is the early ischemia. Now laboratory and the cardiac assessment. So again, as I said, hypoglycemia and stroke symptoms sometimes can merge together and show equal symptoms. So first of all, do the bedside glucose levels, immediate and essential. Then you have to go for the CBC test, platelet counts, electrolytes, renal function test, other chemistry test as appropriate. Coagulation test, ECG and cardiac monitoring, okay. And next is additional test, depends upon the age, history and the type of the stroke or the previous stroke attacks. Now section 4 is going to cover the complications, prevention of the complication. Now what are the complications we have to anticipate before? So first is neurological, we have to anticipate. First is the cerebral edema, increase the intracranial pressure, seizures and neurological deterioration. In respiratory, pneumonia, aspiration pneumonia, hypoxia, secretion, retention. In cardiovascular, we have to see for the arrhythmias, BP instability, cardiac events, mobility, falls, DVT, then again contractures and deconditioning. In skin and nutrition, see for the pressure injuries, dehydration, malnutrition, constipation, and psychosocial, again depression, anxiety, communication difficulty, caregiver burden. So these are the complications we are going to anticipate. Now coming towards our seventh key point, that is prevention of the stroke. So again, these are the common things: exercise, cholesterol control, treat high blood pressure, quit smoking, manage diabetes, eat healthy. Now prevention of aspiration pneumonia, we have seen the red flags, right, in the swallowing assessment. So we have to see for the red flags. So screen swallowing before the oral intake. Keep the head and trunk appropriate elevated if you are giving any feeds. Maintain oral hygiene, follow prescribed diet, supervise feeding when required, monitor cough, voice change and escalate if you find any abnormality. Now prevention of pressure injuries, yes, it is very important, that is repositioning the stroke patient, it is very important. at least make them to sit, okay, give them back massage, okay, give proper skin like do proper oiling of the skin so that the friction does not happen and they are free from the pressure injuries. Then prevention of the DVT, PE and immobility complications. Assess the immobility and venous thromboembolism risk. Encourage safe mobility. Use intermittent pneumatic compression when prescribed. Perform active or passive range of motion exercises. Observe for the unilateral leg swelling, pain, warmth or sudden respiratory symptoms. Do not massage a suspected DVT. And for pharmacological prophylaxis, you have to it is not appropriate to stop the injection Clexane or any thrombolytic drugs immediately for the stroke, that it can worsen the complications. Again, the main aspect is again the prevention of the falls, okay. Next is musculoskeletal complications. So assess balance, weakness, neglect, vision and cognition. Keep call bell near the patient. Do not allow independent ambulation. Use transfer techniques and position the affected shoulder, limb correctly. Avoid pulling of the arm. And refer early to the physiotherapy or the occupational therapist. Now, prevention of the neurological deterioration. So, neurological deterioration can be done by the, which scales we have learned by the ABCD assessment. Next, we have learned the NIHSS scale. Okay, next we are going to see the new scale, that is NEWS2 scale. Okay, so this is again a scoring system that can prevent the chances of the second stroke. So there are again certain parameters that are respiratory rate, next is oxygen saturation, temperature, systolic BP, heart rate and the level of consciousness. So again the scorings are 0 to 4 is low risk, 5 to 6 is medium risk and 7 is high risk. Prevent seizures and the management safety. If a patient at all is going under the seizures, okay, so you can do the seizure management. Okay, let the episode of the seizure happen and then immediately transfer the patient to the hospital. Nutrition, hydration, bowel and the bladder. So assess the nutritional risk and ability to self-feed. Next is monitor intake, output, weight changes and the hydration status. Follow swallowing recommendation before oral nutrition, prevent constipation through mobility, assess urinary retentions and coordinate the dietitian for the nutritional status. Now again psychological, cognitive and the communication complication. Usha madam has beautifully explained the psychological aspects, so I am not going deep into this. But yes, if you see patient with depression, anxiety, okay, ask the patient to vent out, okay, give them small therapies so that he may recover fast. Now secondary prevention, how to prevent the stroke for the second time. So again blood pressure monitoring, diabetes, you have to control your lipid levels, stop smoking, you have to see for the arterial fibrillation and again main common factor is again your lifestyle changes. Family education, okay, teach the family members the Be Fast assessment so that the patient can get early help. Okay, again control the BP, next medications you have to give to the patient, proper follow-up. So all these aspects come under the patient and family education. Okay, now can you answer me this? A 64-year-old man develops sudden right-sided weakness and difficulty in speaking while having a dinner. So his wife says he was normal at 1910. I noticed symptom at 1925. He has hypertension and arterial fibrillation. He takes an anticoagulant, but the family is unsure of the last dose. He is drowsy but arousable. BP is elevated, glucose is normal. So what is the last known well time? Very good, okay. So what is the ABCD priorities? Yes? What will be the ABCD priorities? You are going to check the airway, yes or no? Then breathing, yes? Okay. Next, what focus neurological findings will you assess? So what are the neurological findings you will be doing? Yes? Very good. So you are going to just do the BFAST assessment, right? Then what medication history is critical? Very good. Why must brain imaging be urgent? So which brain imaging will you prefer first? Non-contrast or contrast? Okay, very good. Now next is what complication should you anticipate? What will be the complications? Yes? If you neglect, okay, what is? Time is brain, yes or no? If you neglect this, the complications will be severe and you cannot revert back the patient early. Okay, so what information will you hand over? So in information, what will you hand over? All the history of the patient. Especially, what is the main thing? Last? Yes, okay. So here is the end of the topic, okay. So the key take home message is again stroke, recognize the rapid and document the last known well time. Next is assess systematically the ABCD. Next, image urgently, prevent the complication, prevention continues after the discharge. So I hope everything is clear. Yes? All the 7 aspects are clear. Okay, thank you so much.
Thank you, ma'am, for that comprehensive and clinical relevant session. Your presentation has emphasized how systemic assessment, vigilant observation, and timely nursing interventions can significantly reduce complications and promote safer recovery.
As the healthcare continues to evolve, our practice must evolve with it. Good nursing care should not depend merely on what we have always. It should be guided by the best available evidence, clinical expertise, and the need of our patients. Turn evidence into action and action into better care. Our final scientific session for today is evidence-based practice and service improvement. To conduct this session, we have Ms. Pratiksha Giri, clinical instructor at Riddhivinayak College of Nursing. Ma'am has completed her BSc Nursing from KDA Nursing College, Andheri, and further pursued an MBA in Healthcare Management from Symbiosis Skill and Professional University, Pune. With 4 years of professional experience at Riddhivinayak College of Nursing, she brings together strong clinical knowledge, management skills, and commitment to deliver quality health care and nursing education. It's my pleasure to invite Ms. Pratiksha Giri ma'am to take over the session. Ma'am, the dais is yours.
Thank you, Sudha. Good afternoon, everyone. I think and I hope that everyone is awake. Anyways, नीपू मैम ने बहुत अच्छे questions पूछे थे, तभी सबका response भी अच्छे से आ रहा था. So I think everyone is awake. And we are on the last session of today's CPD program, and I'll be covering topic which is secondary prevention, evidence-based practice, and service improvement related to stroke. So why secondary prevention? हार्ट अटैक एक बार आता है या वापस आ सकता है? आ सकता है ना. सिमिलरली स्ट्रोक में भी यही होता है. ठीक है, एक बार स्ट्रोक हुआ, हमने ट्रीटमेंट दिया, मैनेजमेंट दिया, केयर दिया, जैसे कि हमने प्रीवियस सेशंस में सुना. सो इट डज नॉट मीन कि स्ट्रोक वापस से हो नहीं सकता है. द सेकेंडरी स्ट्रोक कैन ऑल्सो अकर इफ वी डू नॉट give proper secondary, if we do not take secondary measures properly. Okay, what is secondary stroke? A secondary stroke is a major health concern in India where stroke is leading cause of death and disability. ठीक है, फर्स्ट टाइम स्ट्रोक हुआ, हमने कह दिया, पेशेंट ठीक हो गया, रिकवर हो गया, बट इफ़ वी डू नॉट टेक सेकेंडरी मेजर्स, अगेन पेशेंट can go or can get secondary stroke, and that can lead to mortality and as well as long term disability. Recurrent stroke happens when underlying vascular risk remain unmanaged. In primary stroke, we come to know that what are the causes. Okay, so we need to take good care of that, and if we are able to manage that, we can avoid secondary stroke. Why secondary stroke prevention matters? Previous stroke or ischemic attack increases the risk of another stroke. Within a 24 hours or maybe within a week, patient may get secondary stroke. Secondary prevention aims to identify and treat the cause of the first stroke and control modifiable risk factor. Many recurrent stroke can be prevented through appropriate medical treatment and lifestyle changes. There are different causes of first stroke which we need to manage, and another, the lifestyle changes are very much important through which we can prevent secondary stroke. Clinical urgency. High recurrence risk, highest risk occur within, as I already told, कि first 24 hour और first week में वापस से recurrent stroke हो सकता है. ठीक है, जिसके लिए हमें कुछ मेजर्स लेने हैं. पहले तो हमको कॉजेस को देखना है कि क्या कॉजेस प्राइमरी स्ट्रोक के रहे हैं, उनको प्रॉपर ट्रीटमेंट देना है. कॉजेस कैन बी एट्रियल फिब्रिलेशन, कैरोटिड आर्टरी डिजीज, इंट्राक्रैनियल वैस्कुलर डिजीज, डायबिटीज एंड हाइपरटेंशन एंड अदर कार्डियोवैस्कुलर कॉजेस. इम्पैक्ट क्या होता है अगर रिकरेंट स्ट्रोक हो जाता है? तो रिकरेंट स्ट्रोक कैरी हायर रेट्स ऑफ मोर्टैलिटी एंड लॉन्ग टर्म सीवियर डिसेबिलिटी. एक बार स्ट्रोक हुआ, देयर आर चांसेस कि हम प्रॉपर ट्रीटमेंट से पेशेंट को, जैसे मैम ने कहा, नियर टू नॉर्मल ला सकते हैं. बट इफ़ यू डू नॉट टेक केयर प्रॉपरली लेटर, तो उसके बाद जो स्ट्रोक होता है उसमें देयर आर चांसेस कि मोर्टैलिटी हो जाए, पेशेंट मर भी सकता है, या फिर लॉन्ग टर्म डिसेबिलिटी हो सकता है जो कि हम वापस से ठीक नहीं कर सकते. So after treatment, there are, like for after primary treatment, there are certain medication जो patient long term के लिए लेता है to prevent secondary stroke, under which comes the first line monotherapy. ठीक है, these are for long term use and it includes different type of medication such as aspirin or clopidogrel gel. In short term dual antiplatelet therapy, previously it was recommended for around 12 months or 1 year, but now the guideline has changed and they have reduced the timeline to 1 to 6 months where patient take antiplatelet therapy. Once the short term dual therapy ends, we do not directly stop all the medication of the patient. We give patient antiplatelet or anticoagulant but not together because patient might develop the risk of bleeding. The next cause can be arterial fibrillation. ठीक है, arterial fibrillation causes cardioembolic stroke where we give long-term anticoagulation therapy which can be directly given orally. And why? How it helps is it helps by specific chemical receptor responsible for stagnant blood clot. ठीक है, is prevent your blood clotting thing. Timing depend on the physician and depend on the patient condition and severity of the stroke. Next, we need to manage cholesterol also. Why cholesterol management? Because that also lead to clotting or blockage of your arteries, which can lead to stroke. So according to AHA and ACC guideline, LDL should be maintained always below 55 mg per dl in stroke patient. Additional, the therapy which we use in this condition is atorvastatin or rosuvastatin therapy, which is also called statin therapy. Additionally, lipid lowering therapy may be required. If this therapy does not work, additional therapy also may be used by physicians. Next is blood pressure control. Blood pressure control करना बहुत ज़रूरी है, and it is also a modifiable risk जो कि हम control करके patient को secondary stroke से बचा सकते हैं. Hypertension is one of the most important modifiable risk factor. During acute stroke, the brain loses its ability to regulate its own blood flow. ठीक है, during stroke brain जो होता है वो अपना ability lose कर देता है खुद का blood flow का मैनेज करने का. तो किस पे डिपेंड हो जाता है? सिस्टमिक ब्लड फ्लो पे. तो जो फर्स्ट आपके 24 to 72 आवर्स होते हैं वो अक्यूट फेज होते हैं, जिसमें आपको डिफरेंट गाइडलाइंस दिए हैं, उसके अकॉर्डिंग आपको ब्लड प्रेशर को मेंटेन करना है. If the patient come with a clot, okay, and have not received any kind of medications or have not gone under any kind of surgery, then the blood pressure need to be maintained below 180 to 110 mmHg. And if the patient receives any kind of medications or went under any procedures, your target should be maintaining the BP between 180 to 105 mmHg. Once the patient recovers, okay, like we have stabilized the patient, we have done the treatment. After that, the target should be maintaining the BP between below 130 to 80 mmHg. ठीक है, ये तो हम करेंगे. Simultaneously, we need to encourage the patient also to maintain their BP by their own selves. And how can we encourage the patient? We can ask them to continuously monitor their BP when they are at home. ठीक है, they can go to the local clinics, and medication which have been already prescribed, they should take on time and the recommended dose. We can also tell patient and encourage patient to reduce the sodium intake, as हमको सबको ही नमक खाना पसंद होता है, पर हम वैसा नहीं कर सकते if we are suffering from such kind of condition. ठीक है, तो we must tell patient that उनका डाइट में सोडियम कम होना चाहिए. इस अराउंड 1500 to 2000 mg पर डे, इतना ही वो पर डे ले सकते हैं. हेल्दी वेट मेंटेन करने बोलना है. कैसे कर सकते हैं हेल्दी वेट मेंटेन? एक तो डाइट, दूसरा रेगुलर फिजिकल एक्टिविटी. जैसे कि मैम ने भी बोला कि उनको रेगुलरली अराउंड 30 मिनट के लिए एक्टिविटीज़, कोई फिजिकल एक्टिविटी करनी है. एंड इफ़ नॉट पॉसिबल फॉर द पेशेंट, इफ़ दे नीड असिस्टेंट, दे कैन गो फॉर फिजियोथेरेपी. ओके, नेक्स्ट इज ग्लाइसेमिक कंट्रोल. ग्लाइसेमिक कंट्रोल क्यों करना है? क्या होता है ज़्यादा ग्लाइसेमिया होने से बॉडी में या ज़्यादा शुगर होने से? हीलिंग प्रोसेस स्लो डाउन हो जाता है, राइट? तो अगर ब्रेन में कोई इंजरी है तो वहाँ पे इन्फ्लेमेशन होगा बिकॉज ऑफ ज़्यादा ग्लाइसेमिक इंडेक्स. इसलिए हमको ये भी ग्लूकोज को भी रेगुलेट करना है बॉडी में. प्रायरली भी बोला कि 24 आवर्स टू 72 आवर्स आपका अक्यूट फेज होता है, जिसमें आपको इस चीज़ को मेंटेन करना है, आपके ब्लड प्रेशर को भी और आपके ग्लूकोज को भी. एडीए क्या रिकमेंड करता है? बिटवीन 140 टू 180 mg पर डीएल उनका मेंटेन होना चाहिए ग्लूकोज, अगर पेशेंट को स्ट्रोक हुआ है तो. उसको कैसे मेंटेन कर सकते हैं हॉस्पिटल में? बाय एडमिनिस्ट्रेशन ऑफ इंसुलिन. ओके, फिर डायरेक्टली पेशेंट का इंसुलिन बंद करना है क्या? नहीं, बट वी कैन ट्रांसफर पेशेंट टू ओरल मेडिकेशंस. मेटफॉर्मिन सुना है? आई थिंक सबने ही सुना होगा मेटफॉर्मिन. जिसने भी डायबिटिक पेशेंट को देखा है, उनको केयर दिया है, अपने घर में किसी को डायबिटीज़ होगा तो उनके पास ये मेटफॉर्मिन टैबलेट आपको मिलेगा. तो वी कैन नॉट डायरेक्टली स्टॉप द इंसुलिन, वी कैन गिव थ्रू ओरल मेडिकेशन. HbA1c का रिपोर्ट कितने तक होना चाहिए अकॉर्डिंग टू गाइडलाइन? 7.0%. ठीक है, उससे ज़्यादा नहीं. लाइफस्टाइल मॉडिफिकेशन. लाइफस्टाइल मॉडिफिकेशन में 2 इंपॉर्टेंट चीज़ों जिसका ध्यान रखना है, फिजिकल एक्टिविटी एंड स्मोकिंग सेसेशन। ठीक है, फिजिकल एक्टिविटी पेशेंट को एनकरेज करना है कि प्रॉपर फिजिकल एक्टिविटी करे घर पे, पैसिव हो, एक्टिव हो, थ्रू हेल्प हो और थ्रू फिजियोथेरेपी हो। दूसरा, पेशेंट को सिडेंट्री लाइफस्टाइल मेंटेन नहीं करने देना है। समटाइम पेशेंट के अंदर फियर हो जाता है। ठीक है, एक केस मेरे बहुत ही क्लोज पर्सन का है जिसमें उनको इतना फियर हो गया था कि अगर मैं उठूंगा तो गिर जाऊंगा। तो कितना भी उनको हम इनकरेज करते थे, कितना भी कहते थे, वो उठते ही नहीं थे अपने जगह से। ठीक है, लास्ट में वो अभी नहीं है यहाँ पे इस दुनिया में, पर इतने लेवल का फियर भी पेशेंट के अंदर आ जाता है जिससे उनका रिकवरी का चांसेस बहुत ही कम या ना के बराबर हो जाता है। तो इसलिए हमें पेशेंट को मोटिवेट करना है, साथ में रिलेटिव्स को मोटिवेट करना है। स्मोकिंग अगर पेशेंट करता है तो उसको वो लेने के लिए मना करना है। ठीक है, अल्कोहल भी पेशेंट को नहीं लेना चाहिए ऐसे कंडीशन में। साथ ये इस इन सब चीज़ों का हेल्थ एजुकेशन देना किसका रिस्पॉन्सिबिलिटी है? हम नर्सेस का, राइट। हेल्दी डाइट, डैश स्टाइल ईटिंग पैटर्न जिसमें सोडियम इनटेक पेशेंट कम से कम ले, ऐसे डाइट को हमको पेशेंट को एनकरेज करना है लेने के लिए। वेजिटेबल्स, फ्रूट्स, होल ग्रेन्स, लेग्यूम्स, नट्स एंड सीड्स, फिश जैसी चीज़ें पेशेंट ले सकता है। लिमिट क्या करना है? एक्सेस सोडियम, अल्कोहल एंड स्मोकिंग साथ में आता है, प्लस सैचुरेटेड फैट्स कम से कम इनटेक होना चाहिए। शुगर को भी कम से कम लिमिट करना है क्योंकि हमको बीपी एंड ग्लाइसेमिक इंडेक्स को मेंटेन करना है, राइट। पेशेंट को क्या एजुकेशन देंगे एज अ नर्स? रेगुलर फॉलोअप शुड इंक्लूड मॉनिटरिंग ऑफ ब्लड प्रेशर। ठीक है, ब्लड प्रेशर का मॉनिटरिंग होना चाहिए, कोलेस्ट्रॉल का मॉनिटरिंग होना चाहिए और उस पर कंट्रोल होना चाहिए, ब्लड ग्लूकोज का मॉनिटरिंग होना चाहिए, मेडिकेशन प्रॉपर टाइम पे लेना चाहिए। मॉनिटर हार्ट रिदम। ठीक है, पेशेंट को अगर लगता है कि कुछ ज़्यादा फास्ट बीटिंग हो रहा है या स्लो बीटिंग हो रहा है, खुद भी फील कर सकता है ना पेशेंट समटाइम, तो वो उसको तुरंत का रिपोर्ट करना है। मेंटेन वेट एंड फिजिकल एक्टिविटी, अवॉइड स्मोकिंग एंड टोबैको intake. Patients should understand why each medication and lifestyle changes is important and have a clear follow-up plan. Patient कैसे समझेगा? जब हम उसे अच्छे से टाइम दे के, जैसे कि शाम ने बोला कि हमें पेशेंट को टाइम देना है, वही सबसे इम्पॉर्टेंट और डिफिकल्ट काम है, टाइम देना एज अ नर्स, क्योंकि हमें बहुत सारे काम होते हैं। तो उन्हें ये अंडरस्टैंड कराना हमारा काम है और ये टाइम कंज्यूमिंग है, पर ये हमें ही करना है। ठीक है, these were the secondary stroke preventions. Next is current stroke guideline and quality improvement initiatives. Stroke is a medical emergency, as we all know, which required evidence based care. ठीक है, ऐसे ही रैंडमली हम कुछ भी नहीं कर सकते हैं, एविडेंस बेस्ड प्रैक्टिसेस ही हम करते हैं मेडिकल केयर में। करंट गाइडलाइन हेल्प स्टैंडर्डाइज असेसमेंट, ट्रीटमेंट एंड फॉलोअप। सब जितने भी सेशन हुए सब ने इस चीज़ पे एम्फसाइज किया है कि प्रॉपर असेसमेंट होना चाहिए। टाइम इज ब्रेन। ठीक है, टाइम पे असेसमेंट होना चाहिए, टाइम पे ट्रीटमेंट होना चाहिए और टाइम पे फॉलोअप भी होना चाहिए टू प्रिवेंट सेकेंडरी स्ट्रोक। क्वालिटी इंप्रूवमेंट इनिशिएटिव हेल्थ केयर सिस्टम मेजर्स एंड इम्प्रूव स्ट्रोक केयर। जो भी प्रैक्टिसेस ऑलरेडी एविडेंस बेस्ड प्रैक्टिसेस हैं वो हैं, लेकिन साथ में क्वालिटी इंप्रूवमेंट इनिशिएटिव्स क्या करता है, हमें ये अथॉरिटी या एसएस हेल्प करता है कि हम उस प्रैक्टिसेस को करते करते उसको मेजर कर सके वेदर दैट इज प्रॉपरली वर्किंग फॉर माय पेशेंट और नॉट। ठीक है, इफ इट्स नॉट वर्किंग या आउटकम वैसा नहीं आ रहा जैसा हमें चाहिए, तो वी कैन ऑल्सो इम्प्रोवाइज इट। ओके, दिस इज करंट स्ट्रोक गाइडलाइंस 2026 AHASA Acute Ischemic Stroke Guidelines. It was again published in January 2006, which had come in 2018 and 2019 was updated. Okay, what it includes? The key update includes improved pre-hospital stroke system. What is pre-hospital stroke system? There is a team which is formed, which act on specially stroke cases, where they use mobile unit. They can directly contact to patient or relatives and use the scale to measure stroke if the stroke is there or any other कंडीशन. कैसे स्ट्रोक मेजर करेंगे वो लोग, कौन सा स्केल यूज करेंगे, फास्ट ना, बी फास्ट. तो फोन पे ही वो बात करके पता कर सकते हैं वेदर स्ट्रोक हुआ है या कुछ और. ठीक है. उसके बाद दे कैन यूज द ट्रायल सिस्टम. ट्रायल सिस्टम क्या कहता है, कैसे हेल्प करता है, टू आइडेंटिफाई विच केस इज important and it immediate care, right? Trial system they will use and they will direct the patient कि नियर बाय हॉस्पिटल में, लोकल हॉस्पिटल में जा सकते हैं या डायरेक्ट स्पेशलाइज हॉस्पिटल में उनको भेजना है. ठीक है. टेनेक्टिव प्लेस और एंटी प्लेस मैम ने ऑलरेडी कवर किया था अपने इसमें सेशन में. क्या होता है, ड्रग होता है जिससे क्लॉट को हम रिमूव करते हैं. ठीक है. उसका विंडो पीरियड क्या है वो भी मैम ने बोला था, विद इन 4 to 5 आवर्स हमको उसको एडमिनिस्टर करना है. जैसे ही असेसमेंट हो जाता है, हम श्योर हो जाते हैं कि स्ट्रोक है, तुरंत हमको ये मेडिकेशन पेशेंट को एडमिनिस्टर करना है. एक्सपांडेड एलिजिबिलिटी ऑफ एंडोवैस्कुलर थ्रोम्बेक्टमी ईवीटी अप टू 24 आवर्स. पहले क्या होता था कि जैसे ही पेशेंट अराइव होता था विद इन 12 आवर्स इट वाज इम्पॉर्टेंट कि डिसीजंस लिया जाए और तुरंत सर्जिकल प्रोसीजर किया जाए. बट देन न्यू गाइडलाइन सजेस्ट कि नहीं, हमको 12 आवर, अगर हमको 24 आवर्स लेना है टू बी श्योर, देन मेडिकल टीम और द फिजिशियन कैन टेक 24 आवर्स एंड डिसाइड which kind of surgery or which kind of medication is patient needed. ठीक है. तो अभी वो विंडो पीरियड जो है 24 आवर्स तक एक्सटेंड कर दिया है. न्यू रिकमेंडेशन एड्रेसिंग pediatric ischemic stroke. Earlier or the guideline were only about covering only about adult stroke. Now the new guideline covers pediatric stroke therapy as well. Okay. Quality improvement initiative. It focuses on reducing treatment delays. जैसे कि बार बार वो टर्म यूज़ किया है, टाइम इज़ ब्रेन. तो डिले हम अफोर्ड नहीं कर सकते ऐसे केसेस में. जैसे कि कार्डियक अरेस्ट में हम डिले कर सकते हैं क्या, अफोर्ड कर सकते हैं टाइम को डिले करना, नहीं. वैसे स्ट्रोक में भी हम अफोर्ड नहीं कर सकते टाइम को डिले करना. क्यों, जितना डिले करेंगे उतना मोर्टालिटी रेट बढ़ने का चांसेस है या फिर लॉन्ग टर्म डिसेबिलिटी होने का चांसेस है. एम्फेसाइज रैपिड स्ट्रोक टीम एक्टिवेशन, imaging and thrombolysis. These initiatives help translate guideline into consistent bedside practice. What it includes? Door to imaging time. ठीक है. As soon as patients arrives in the hospital, हमको within hour, जैसे मैम ने बोला कि 60 minutes या within an hour हमको डिसाइड कर पेशेंट का केयर स्टार्ट करना है, जो कि स्टार्ट होता है इमेजिंग से. इमेजिंग से क्या पता चलेगा, टाइप ऑफ स्ट्रोक ना. हमको टाइप पता करना ज़रूरी है, बिना टाइप के हम डायरेक्ट ट्रीटमेंट स्टार्ट नहीं कर सकते. तो टाइप पता करने के लिए कि कौन से टाइप का स्ट्रोक है वो हमको इमेजिंग में ही पता चलेगा. डोर टू नीडल टाइम, इसमें क्या होता है, ड्रग. ठीक है. जैसे ही पता चलेगा वैसे ही हम उस टाइप का स्ट्रोक के टाइप का ड्रग एडमिनिस्टर कर सकते हैं ताकि क्लॉट रिजॉल्व हो सके. डोर टू डिवाइस टाइम फॉर थ्रोम्बेक्टमी. अगर क्लॉट मेडिसिन से नहीं निकल सकता है, डिजॉल्व नहीं हो सकता है, तो प्रोसीजर का ज़रूरत पड़ेगा. तो विच टाइप, कौन सा टाइप का प्रोसीजर, कौन सा प्रोसीजर पेशेंट को करना है, उसको हमको डिसाइड करना है. ये सब कितना टाइम लेना चाहिए, ज़्यादा से ज़्यादा 60 मिनट से कम. ठीक है. 60 मिनट के अंदर ही ये सारी चीज़ें हमको डिसाइड करनी है. अप्रोप्रिएट थ्रोम्बोलाइसिस, अप्रोप्रिएट थ्रोम्बेक्टमी, डिस्फेजिया स्क्रीनिंग. ठीक है. डिस्फेजिया इज डिफिकल्टी इन swallowing. Anti-thrombotic therapy, anticoagulation when indicated for atrial fibrillation, smoking cessation, statin therapy and rehabilitation assessment. ये सारी चीज़ें हमें मॉनिटर करनी है और स्टार्ट करनी है अंडर क्वालिटी मेजर्स. की कॉन्सेप्ट क्या है इसका, मेजर करना, आइडेंटिफाई गैप. ठीक है. मैम ने लिया ऑलरेडी कि टाइम क्या क्या किस चीज़ में होना चाहिए, कितना लेना है. इंटरवीन, सारी चीज़ें करने के बाद हमको उसको रीमेजर करना है, पेशेंट पे कितना काम किया या और क्या मॉडिफिकेशन चाहिए, एंड इम्प्रूव. ठीक है. यहाँ पे हमारा आता है क्वालिटी इम्प्रूवमेंट या सर्विस इम्प्रूवमेंट. It also include multidisciplinary team, emergency physicians, neurologists, nurses, EMS, pharmacist, neuro interventional specialist, physiotherapist, occupational therapist, speech and language therapist and rehabilitation team. सिर्फ एक जन का काम नहीं है, ठीक है, पूरा एक टीम लगता है ऐसे केसेस को मैनेज करने के लिए और पेशेंट को नियर टू नॉर्मल लाने के लिए, ठीक है. एज ए नर्सेज हमारा क्या रोल है, अर्ली रिकग्निशन, ठीक है. एज अ नर्स हो सकता है एक नॉर्मल पेशेंट और किसी और कंडीशन से हॉस्पिटल में एडमिट हुआ हो, बट एज अ नर्स अगर हमको क्वालिटी इंडिकेटर्स पता है, हमको पता है कि एविडेंस बेस्ड प्रैक्टिसेस के अकॉर्डिंग हमको चीज़ें पता है, बी फास्ट स्केल पता है, तो हम उसको अर्ली आइडेंटिफाई कर सकते हैं कि ये पेशेंट स्ट्रोक से सफ़र कर रहा है या उसको स्ट्रोक का अटैक आया है, ठीक है. न्यूरोलॉजिकल मॉनिटरिंग NIHS स्केल था, ठीक है, वो सारे स्केल यूज़ कर सकते हैं. मेडिकेशन सेफ्टी में हमारे हाथ में ही है, मेडिकेशन तो डॉक्टर लिख देंगे, ठीक है, पर सही से देना, सही रूट से देना, सही डोज देना वो हमारे हाथ में है. डिस्फेजिया स्क्रीनिंग, डायरेक्टली पेशेंट को स्ट्रोक होने के बाद, मेडिकेशन स्टार्ट करने के बाद, सर्जरी वगैरह होने के बाद डायरेक्टली कुछ भी खाने को देना नहीं है, पहले उसका असेसमेंट करना ज़रूरी है वेदर द पेशेंट इज एबल टू स्वॉलो और नॉट, ठीक है. डायरेक्टली देंगे तो क्या होगा, पेशेंट में एस्पिरेट. प्रिवेंशन ऑफ कॉम्प्लिकेशन, हम प्रॉपर ट्रीटमेंट केयर देंगे तो कॉम्प्लिकेशंस नहीं होंगे. कॉम्प्लिकेशंस कौन कौन से थे ऑलरेडी हमने प्रीवियस सेशन में देखे. पेशेंट एजुकेशन, पेशेंट को समझाना आगे क्या करना है, कैसे करना है, फैमिली को समझाना, ये भी हमारे रोल में आता है. क्वालिटी डेटा कलेक्शन थ्रू आउट ट्रीटमेंट, ठीक है, हम क्वालिटी डेटा कलेक्ट कर सकते हैं जो कि evidence based practices बनेंगे which we can use in future and other can also refer from that. Next, evidence based practice in stroke. What is evidence based practice, EBP? It means making clinical decision by integrating 3 important components. What are those components? Best available research evidence. हम लोग कुछ भी हॉस्पिटल में ऐसे ही करते हैं क्या, नहीं. ऑलरेडी जिन चीज़ों पे, जिन प्रैक्टिसेस में रिसर्च हो चुकी है, उनके आउटकम हमको पता है, वही चीज़ें हम उन चीज़ों को हम प्रैक्टिस में लाते हैं, है ना. और मोस्टली वो यूनिवर्सली यूनिफॉर्म ही होते हैं, जैसे कि हैंड वॉशिंग, है ना, एविडेंस बेस्ड प्रैक्टिसेस है और यूनिवर्सली वो एक ही जैसा फॉलो होता है. क्लिनिकल एक्सपर्टीज, व्हाट डज द नर्स नो फ्रॉम प्रोफेशनल एजुकेशन, स्किल एंड क्लिनिकल एक्सपीरियंस, ठीक है. हमको एविडेंस बेस्ड प्रैक्टिसेस पता होना चाहिए. साथ में जो हम एज अ नर्स, हमें अपने आप को भी अपडेट और स्किलफुल रखना है, तभी हम केयर प्रोवाइड कर सकते हैं. पेशेंट वैल्यू एंड प्रेफरेंसेस, व्हाट मैटर्स टू द पर्टिकुलर पेशेंट एंड फैमिली. पेशेंट और फैमिली को भी के वैल्यूज़ को भी हमको ध्यान में रख के केयर डिज़ाइन करना है. देयरफॉर EBP is equal to best evidence plus clinical expertise plus patient value. Evidence-based practice is not simply following a research article or protocol. Turn evidence into action, turn action into care. ये छोटा सा एक सिनेरियो है या फिर केस है, उसको देखते हैं. A 62-year-old patient suddenly develops facial drooping. हमने सीखा what is facial drooping? Weakness of right arm and difficult speaking. One nurse immediately recognized fast symptoms. एक नर्स है, 2 नर्सेस है, एक नर्स है जिसको ऑलरेडी फास्ट स्केल पता है. What is fast scale? F is for facial drooping, A is for arm weakness, S speech and T is for time. ठीक है. So she activates the stroke pathway. She alerts the team and checks blood glucose and ensure rapid assessment. जो early assessment है वो start कर देती है. Another nurse है who waits for the doctor to arrive before initiating the pathway. जिसको शायद पता ही नहीं है फास्ट असेसमेंट क्या होता है और आगे मुझे क्या करना है, वो आइडेंटिफाई नहीं कर पा रही कि पेशेंट ऐसा कुछ सिम्टम्स दिखा रहा है, ठीक है. तो आपको क्या लगता है, विच पेशेंट हैज अ बेटर चांस ऑफ फेवरेबल आउटकम? द डिफरेंस इज नॉट मेरली एक्सपीरियंस, वेदर The current evidence have been translated into routine clinical practice. कौन से केस में पेशेंट का रिकवरी चांसेस अच्छा है? जिस नर्स ने अर्ली रिकॉग्निशन किया, अर्ली असेसमेंट स्टार्ट कर दिया है और जल्दी से टीम को अलर्ट किया, उस केस में रिकवरी चांसेस ज़्यादा बेटर होंगे, है ना? इन स्ट्रोक द टाइम इज पर्टिकुलरली इंपॉर्टेंट बिकॉज टाइम इज ब्रेन. But evidence-based stroke care does not stop after the emergency phase. It continues through recognition, जैसे कि पहले ही बोला, ठीक है? स्ट्रोक का केयर वहीं पे ख़त्म नहीं होता है कि स्ट्रोक हुआ तो हमने पेशेंट को केयर दिया और पेशेंट ठीक हो गया, नहीं, वहीं पे नहीं ख़त्म होता है. अगर केयर कंटिन्यू नहीं किया तो देयर आर चांसेस कि सेकेंडरी स्ट्रोक भी होगा. उसके लिए क्या करना है? रिकग्निशन करने आना चाहिए, अक्यूट केयर देना है, प्रिवेंशन ऑफ कॉम्प्लिकेशन, रिहैबिलिटेशन, उसके बाद सेकेंडरी प्रिवेंशन के अंदर जो भी चीज़ें आती है हमें उस चीज़ को फॉलो करना है. लॉन्ग टर्म रिकवरी एट एवरी स्टेज नर्सेज इन्फ्लुएंसेस आउटकम. वी ऑल एग्री ऑन दैट. Case 2. A 70-year-old woman is admitted following an acute stroke. She has left side weakness, mild facial drooping, difficulty swallowing, limited mobility, hypertension and difficulty in communication. What evidence-based nursing priorities do you identify? Expected response as a nurse should be immediate or ongoing assessment. सबसे पहले assessment, ठीक है? Neurological monitoring, vital signs, glucose where indicated, observe for deterioration. ठीक है? पहला assessment करना आना चाहिए तो ही हम कर सकते हैं. तो सबसे पहले असेसमेंट से स्टार्ट होगा, एज हमसे एक्सपेक्टेड है एज अ नर्स से. स्वॉलोइंग में अवॉइड अनसेफ ओरल इनटेक, अप्रोप्रिएट स्वॉलोइंग असेसमेंट करना है पहले, कुछ भी देने से पहले. एस्पिरेशन प्रिकॉशंस, पेशेंट को एस्पिरेट ना हो इस चीज़ का हमको ध्यान रखना है. वो हम कैसे कर सकते हैं? स्वॉलोइंग असेसमेंट से. मोबिलिटी, फॉल असेसमेंट, प्रेशर इंजरी प्रिवेंशन, सेफ पोजिशनिंग, रिहैबिलिटेशन इन्वॉल्वमेंट. कम्युनिकेशन में सिंपल लैंग्वेज यूज़ करना है. मैम ने बोला कि ऐसा नहीं है कि पेशेंट यहाँ से वीक हो गया है, ठीक है? उसका इंटेलेक्चुअल लेवल वही है, बस क्या हो रहा है, फिजिकली डिटोरिएट हुआ है पेशेंट, डिसेबिलिटी आई है, ठीक है? तो सिंपल लैंग्वेज में कम्युनिकेट करना है, पेशेंट विल अंडरस्टैंड. एडिक्वेट रिस्पॉन्स टाइम, पेशेंट को टाइम देना है रिस्पॉन्स करने के लिए. क्यों? स्पीच में प्रॉब्लम हो सकता है, इसलिए पेशेंट को इनफ टाइम देना है कि वो अपने आप को एक्सप्रेस कर सके. कम्युनिकेशन एड वेयर रिक्वायर्ड. कम्युनिकेशन एड क्या हो सकता है? साइंस हो सकता है, वी कैन यूज द साइंस. और इफ पेशेंट नो हाउ टू राइट, पेशेंट को हम राइटिंग मटेरियल भी दे सकते हैं, है ना? साइकोलॉजिकल केयर, इन्वॉल्व द पेशेंट. पेशेंट का इन्वॉल्वमेंट जरूरी है. पेशेंट के विल के अगेंस्ट हम चीज़ें नहीं करते हैं, ठीक है? सेकेंडरी फेज और रिहैबिलिटेशन फेज की बात हो रही है. प्रोवाइड रिएश्योरेंस विदाउट इन्फेंटिलाइजिंग, असेस इमोशनल वेलबींग, इन्वॉल्व फैमिली अप्रोप्रिएटली. जैसे कि मैम ने कहा कि सबसे ज़्यादा प्रॉब्लम किसको होता है? खुद पेशेंट और उसके रिलेटिव्स को. नर्सेस फुल टाइम पेशेंट के साथ नहीं होने वाले हैं, और कब तक होने वाले हैं? जब तक पेशेंट हॉस्पिटल में है ना? तो पेशेंट का और फैमिली का इन्वॉल्वमेंट ज़रूरी है ताकि वो घर पे जाके आफ्टर केयर ले सके. सेकेंडरी प्रिवेंशन, मेडिकेशन अधेरेंस एजुकेशन, पेशेंट को मेडिकेशन के बारे में एक्सप्लेन करना है, रिलेटिव्स को एक्सप्लेन करना है. ब्लड प्रेशर मैनेजमेंट के बारे में उनको समझाना है. लाइफस्टाइल एंड रिस्क फैक्टर एजुकेशन के बारे में भी उनको अवेयर करना है. सो इफ यू आस्क आवरसेल्व्स अ क्वेश्चन, if we know all of this good practice, how do we ensure every stroke patient in a hospital receives it? If we ask ourselves this question, the answer will get from us only that evidence-based practice plus service improvement. The last is patient education. Patient education is an essential part of stroke management. Teach the patient and family about स्ट्रोक वार्निंग साइन फास्ट, ठीक है? फेस ड्रूपिंग, आर्म वीकनेस, स्पीच डिफिकल्टी एंड टाइम टू सीक इमरजेंसी केयर. पेशेंट को और फैमिली को दोनों को इस चीज़ के बारे में आपको समझाना है, बताना है. medication adherence, blood pressure and diabetes control, healthy diet and physical activity, smoking cessations, follow-up and rehabilitation, recognition of recurrent stroke symptoms. ये सब चीज़ों के बारे में पेशेंट और फैमिली दोनों को पता होना चाहिए ताकि वो क्या प्रिवेंट कर सके सेकेंडरी स्ट्रोक. Education should be simple, clear and culturally appropriate. Individualized according to the patient deficits, repeated and reinforced. ठीक है, sometime patient may say that I am tired, I don't want to get up, I don't want to walk. तो क्या करना है? Give up करना है क्या? नहीं. Give up करेंगे तो long life disability हो जाएगा. तो patient को encourage करना है, reinforce करना है कि patient treatment में participate करे actively and willingly. Important topic. Recognize warning sign of recurrent stroke, medication adherence, blood pressure and diabetes monitoring, healthy diet and physical activity, again smoking cessation, follow-up and rehabilitation, and patient and family should know that when and how to seek emergency medical care. Let us all conclude the last session. Evidence-based practice is essential for effective stroke care. Clinical decisions should be based on research evidence plus clinical expertise plus patient preferences. Patient and family education promotes self-management and prevent reoccurrence. अगर reoccurrence को हमको prevent करना है तो patient और family का educate होना important है क्योंकि हम उनके घर पे तो नहीं होंगे, वही होंगे, patient खुद होगा और उनके family members होंगे. EBP ultimately improves quality of life, recovery and patient safety. Thank you all.
Thank you, ma'am, for the valuable session. You have encouraged us not only to provide care, but also continuously question, evaluate, learn, and improve the care we provide. Indeed, better evidence leads to better practice, and better practice leads to better patient outcome. Let's appreciate ma'am with a round of applause.
Now I would like to invite one of our nursing professionals from the audience to kindly come forward and share their valuable feedback on today's CPD session. So, is there anyone who can come forward and give us a feedback for today's sessions? We would like your response. Yes, ma'am. Yes, anyone from back audience there? Your good name, ma'am? So we will hand over the mic to Ms. Shambhavi. Thank you.
Good afternoon to all. So this is Miss Shambhavi. So as workshop is conducted on this stroke care and essentials. So it was very wonderful session conducted by Riddhi Vinayak College of Nursing. It is really essential topic. Like most of the peoples, they go ahead with the like heart related, like MI they go. But stroke also is very important neurological emergency which we come across as a healthcare professionals. And it is really important not only in educational but in clinical setup. And in educational setup, definitely when we are teaching to our nursing students when they are going to emergency care, so how they have to manage. Be fast is very important, that they can rule out. Like I would like to share this experience. I have also taken the same similar topic. Once they went to emergency care and they have seen like these patients. So that time they were able to find out the sign and symptoms in patient, not only correct be fast, but some of the sign and symptoms they were able to rule, they were able to approach doctor and they would provide emergency care. So that is very, very important in nursing field, what I feel. So thank you, ma'am, for conducting this session, and thank you MNC also for this beautiful session. Thank you so much.
Thank you so much, Ms. Shambhavi ma'am, for sharing your valuable feedback with us. Your observation and suggestions are truly appreciated, and will help us improve our future CPD sessions. Thank you once again for your time and valuable contribution.
As we come towards the conclusion of today's program, we would be privileged to hear the observation and valuable feedback from our center observer, Dr. Vidya Gupta ma'am. Insight and suggestion will certainly encourage us to give us guide in making our future programs even more meaningful and effective. Okay, so Dr. Vidya Gupta ma'am is specialist in MedSearch.
MedSearch. You know, MedSearch is our heart, where, as we say, when we go to the specialities, we say the community is the mother of all the specialities. OBGY is, you know, all caretaker. But when we go to the MedSearch, it's all-rounder, because it has to start from the, right from the casualty till the, what do you say, rehabilitation and the following things. So first of all, I'd like to thank MNC for giving me the opportunity as being the observer for this esteemed institute. I thank Riddhi Vinayak Hospital and especially Madam Muka for giving me the opportunity to come here and observe the lectures which is given by the immense delegates who had done the intense study. And I'm much impressed with the use of AI in making the PPTs and in the explanations. I hope the audience have understood the things. Are you well okay with English? Till now all the sessions were in the English only. पण मला असं वाटतं थोडंसं मराठीत गेलेलं जास्त बरं राहील. हा जो टॉपिक तुम्ही घेतला तो खूप छान टॉपिक होता. ॲक्च्युली जसं आता एका यांनी सांगितलं की मल्टिपल टाइम्स वी आर जस्ट फोकसिंग ऑन द हार्ट. ऑफकोर्स वी लव द हार्ट. But then it is not the only system which is to be taken care of. So here the organizers has given the best topic to you, including all the aspects of it, especially the evidence-based practice where we are, providing the cares on the base of the evidences. And because of that, we are getting the specialized in the care. As a nurse, आपण सगळेच leader आहोत. We need not be telling anyone to come forward and tell. आणि इतकं रिक्वेस्ट करायला नाही लागायला पाहिजे. You are working in the ICUs, you are one of the most, important leaders. तिकडे तुम्हाला सांगावं नाही लागत, your patient is getting bad, या आणि करा काहीतरी. No, it is not like that. So everywhere the initiation has to be like that. Be comfortable in your own language. काही प्रॉब्लेम नाही आहे. मराठीत बोललं तर काही केअर चेंज होणार आहे का? नाही होणार आहे. You use your own language and show your confidence, and once you start showing once, you will get the confidence for the second session for 2 more sentences. So please boost yourself. Thank you so much, and I congratulate this institute, and many more such occasions should come. As ma'am said, her vision is there to start with the stroke unit. I am giving the best wishes for that, because it is very important in these areas where medical care is a little bit lagging. So here if you get those kind of clinics, the people will be very much benefited. Thank you so much.
Thank you, ma'am. Your observation and suggestion was truly appreciated and will help us improve our future CPD sessions. Here we come to the end of all sessions for today. As we conclude our today's CPD program, I hope this day has been a meaningful journey of learning, sharing, and professional growth for each one of us. As we close, I would like to leave you with one simple yet powerful message. Recognize fast, act fast, save lives. May the knowledge gained today not remain within this hall, but translate into quicker recognition, better clinical decisions, compensate nursing care, safer recovery, and ultimately better outcomes for our patients.
On behalf of Riddhivinayak College of Nursing, I extend a sincere gratitude to all our resource persons for sharing their valuable time, knowledge, and expertise with us. I would like to express a special gratitude to our center observer, Dr. Vidya Gupta ma'am, for her gracious presence, guidance, and for being here with us throughout our program. A heartfelt thank you to our organizing team, faculty member, and students whose effort and coordination make this program possible.
We also extend our sincere appreciation to all the participants from various nursing institutes. Your presence, enthusiasm, and active participation made this CPD program truly meaningful.
So now we formally bring today's program to an end. So I request everyone to kindly raise and stand in attention for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे भारत माता की वंदे।
बाहेर पोस्ट टेस्ट आणि फीडबॅकचे QR कोड ठेवलेत, तर प्लीज सगळ्यांनी पोस्ट टेस्ट आणि फीडबॅक देऊन मग जाऊ शकतात. ठीक आहे, थँक्यू.